Okay, good afternoon. I'm calling this roundtable to order. Today is Wednesday, March 26, 2025. The time is 1:06 p.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today, we're holding this roundtable jointly with the Committee on Executive Administration and Labor to hear from the public as well as executive regarding challenges district residents and workers face in the district's task to support the health and well-being of our aging population and long-term care workforce. In 2019, the district was home to nearly 84,000 older adults. The council's Office of the Budget Director projected that by 2030, this population could increase by over 50%. To support our older residents, it is crucial that the district have sufficient clinical and non-clinical workforce. A recent DC Health workforce survey showed that between 2020 and 2024, nearly 4,000 certified home health aides and certified nurse aides in the district did not renew their credentials. The percent of HHAs in the district decreased by 13%, and the percent of certified nurse assistants decreased by 28%. Currently, there are about 11,466 CNAs and HHAs certified to work in the district. Data has also shown that based on the current trajectory, the district is expected to only grow its direct care workforce by about 17% by 2032, which will meet about 10% of the job openings in that same timeframe. In plain numbers, we currently have around 11,000 CNAs and HHAs, and we'll need about 25,000 come 2032. Notably, over 80% of these healthcare support services and direct care workers are women and individuals of color. These jobs are challenging and require mental and physical work. These people work in these jobs are integral to our system of caretaking for elderly and deserve our attention as well as our investment. Another factor contributing to the decrease in workforce is a reduction in training programs. 4 schools that had previously offered CNA and HHA training shut down since 2021, and another one closed just last year. We need to ensure that training programs are supported and that we're holding them accountable to have well-trained workforce sufficient to meet the need and demand. The district released its second ever Olmstead Plan, which lays out the goals and priorities for 2025 and 2025 through 2027 to ensure that residents with disabilities are able to live in the community in the most integrated settings possible. However, without sufficient workforce, this option will also be limited as well. I believe it's crucial for the district to be prepared to take care of its most vulnerable residents who need long-term care and simultaneously caring for the workers of those residents. The committees on health and executive administration are working together on health and workforce-related strategies to support and build out the long-term care workforce. And we're holding this roundtable today jointly to hear strategies. I'll now turn to my co-chair, at-large Councilmember Anita Bonds, who is the chair of the Committee on Executive Administration and Labor. Councilmember Bonds.
Thank you. Thank you very much. And good afternoon, everyone. As mentioned, I'm at-large Councilmember Anita Bonds, and my Committee on Executive Administration and Labor is concerned with the plight of services for our senior population. We want to make sure that everyone has an opportunity to age with dignity in the District of Columbia. So I'm particularly interested in what will be presented to us today. And I'm joining my colleague because this roundtable is a status on long-term care workforce in the District of Columbia. And I hope today to hear from DC Health, Department on Aging and Community Living, and the Hospital Association, as well as other advocacy groups who are involved in this important area of health and workforce policy that affects our aging community. The district, as you know, is home to a large and vibrant senior community, which the council's budget director projects will continue to grow and exceed 103,000 people in a very few years, 2030. When we first looked at this number, we said, oh, 2030, 10 years away, certainly 5 years away, but now it's becoming even closer. And this will represent a 25% increase from 2020 in our population. I'm looking forward to hearing from the witnesses about how we can work together so that seniors and our aging residents are able to easily access high-quality care no matter their living environment. How these residents access health care, connect with the healthcare provider community is equally important. I'm glad that today we will hear about the Medicaid waiver system and its application as well. Moreover, our long-term care workforce, it certainly is facing a crisis. Much public concern is focused on needing specific type of health assistance in consideration of the housing or living environment that one may find themselves in. Conversations have focused on needing home care aides, nursing assistants, therapists, workers for assisting living facilities, and the various other types of health practitioners services that are necessary to care for patients residing in our nursing homes or any other specialized residential care facility. All these long-term housing situations require healthcare workers while we face the tremendous deficit of these providers that are needed to fill these critical positions. In 2023 alone, according to the Board of Nursing, the district's direct care workforce shrunk, and a loss of about 30% from just the prior year. Surveys conducted by the DC Coalition of Long-Term Care, which included the coalition's annual discussions with their members and testimonies from direct care workers themselves, shows that the primary reason why workers leave is low pay and burnout. The pipeline of new workers is shrinking. Currently, we can only replace a small number of workers who are leaving the industry, and many of the new workers do not stay long. The gap between the number of workers needed to meet current demand and future needs is exhausting, to say the least. How does DC grow the number of workers needed to serve persons suffering from Alzheimer's or requiring mobility assistance following an extended hospital stay, or suffering from chronic falls or stroke, or simply aging and requiring 24/7 care? These dynamics are considered daily as the city grows older every day. Ensuring that our seniors and disabled residents receive the long-term care they need necessitates expanding the field of providers. Our government recently prioritized pay increases for providers of early childhood care. Have we considered the same for our long-term care workers? How focused is our community on helping people to live with Alzheimer's or dementia in general? And what health care assistance and therapies are offered to individuals recovering from strokes or hospitalization? So I hope today the testimonies we receive will provide us with information and perspectives that will inform our efforts here at the council to create pathways to employment in long-term care, and particularly including our district residents in those occupations. And so, thank you very much for an opportunity to put our seniors front and center in today's hearing. Thank you, Chairwoman.
Thank you. And if any of our colleagues join us, we'll certainly turn to them. All right, so just a little heads up in terms of where we're going today. We'll first hear from our public witnesses, and then we'll turn to our agencies. We'll have testimony from DC Health as well as the Department of Aging and Community Living. We've also received written testimony from the Office of the State Superintendent of Education, as well as the Director of the Department of Healthcare Finance, and those testimonies are available on the DC Council website at dccouncil.gov/hearings if anyone is interested in that. Before we turn to the public witness testimony for those who are in the room, we have 6 pre-recorded testimonies from our home health aide workforce, as well as residents who receive home health care. They do not have the ability to come in person or to testify virtually. So we're still pleased that we were able to make these accommodations to be able to hear their perspectives, which I believe are critical to this discussion. And I do want to extend a thank you to Sal Saveggio, who's here, for helping us coordinate this with my staff. All right, so the first one we'll go to is Angela Weddington. And you, for those who are in the rooms, you'll see it on the screen.
My name is Angela Weddington, and I've been a supportive staff here with Home Care Partners about 10 years now. As of July, enjoy what I'm doing. I've been doing this actually in conjunction to the 10 years, moving over about 20 some years. Started off taking care of my grandparents at an early age of my life. And then promoted from there. I always grew a passion for taking care of the elderly. And that's where my sense of, compassion came from for wanting to help elders. So for the most part, and what I do on and on basis, day to day, I pretty much find out what their needs is. Once I find that out, then in every environment you go to, every home is a little different. But the biggest of what I do is cooking. I do cleaning. I do things of safety, making sure that things are well kept and there's no trip hazards. Make sure there's no fall preventions in the bathrooms or the kitchens, things of that nature. Another thing in addition is that why we're needed is because there's a lot of things that go on in the home, and it's always good to have an overview of someone from the outside to see what's going on within. So knowing that the government has a lot of help and support to help these people, so the more that they're involved, the more they should be, allowed to know. Okay. And also, just to add, just to look at if you don't have an aide, how much more of an impact it really would be to the client themselves when they don't have any kind of support system there to help them. So we are really needed. Because it's like we do a number of things, some things you're almost like a secretary and a chef or something as a planner, but it's always something additional to what is always given. So we are needed. So with the aspect of the things that we entail as far as the duties, the more skills or the more experience that we are actually inhibited to do, I agree that we should be paid more than what we are at minimum, just because of the skills we come in, almost just like somebody going to college and getting a degree to learn things. So yeah, I do agree that the pay should be much more.
Okay. The next one we will hear from is Letitia Teemer. Oh.
Letitia Teemer. My name is Letitia Teemer. I work for Home Care Partners, and I've been here 21 years. I think the importance of my job is trying to help out the families, because a lot of times families, when I get there 8 in the morning, they're preparing to go to work. So that helps them where I'm able to get them up, fed, clothed, wash clothes, clean up, tidy up. So I think that really helps a lot of families when they have somebody there, because a lot of times family doesn't have that time once I get there at 8 o'clock. So I really think it helps. For me, I think the pay for a single parent, I work 7 days a week. It's very hard. I don't get no assistance from the government but what I get from work. So I really think that would help out a lot of people like me. It would cut down the hours where I could spend more time with my family. I have lost a lot of time with my kids because I work every day. When I leave Home Care Partners, I'm back at work. So sometimes it's not easy. Transportation is, the key. Some people are not fortunate to drive a car, and a lot of times that's because of what the bills and stuff is. It might prohibit them from having a car. So going from bus to bus is very hard. It's not easy. I see that me being able to drive to another case is more easier for me because me personally, I have did 4 people in one day. Sometimes I'm not getting off until 9 o'clock at night, just so it could be coverage. It gets a little overwhelming sometimes. I think if we did have more aides to come out, you can kind of stretch certain things, certain times, especially when people want a certain time. And not having another aide is trying to fit that into the schedule, or if somebody calls off, they trying to call the office to make sure. I think if we were able to have more aides, that would make the job for the other aides that's already in the house a little bit easier. Good. I think for me, if the pay goes up, you see a difference. Living, paying rent, kids are very expensive. So I think that for me, if people could really see the help that we do in these houses, to see that we are worth a lot. We're not asking for a lot, but we just asking for enough to be comfortable.
All right. The next person is Lillian Nichols.
Good afternoon. My name is Lillian Nichols, and I've been working for Home Care Partner for 18 years. Also, I worked for Arlington County for 26 years. I provide for the clients is that I do their personal care, breakfast, dinners, and light housekeeping. And I also help them with anything that they need to be that they cannot do for themselves. There's times when we had clients that I have had that the families wasn't there, and I was gladly to step in to help, the loved ones, because we never know what day or what time that we might need that help. And it's very important for us to step in and help the loved ones to take care of their parents and others' loved ones. What they can do is train more people, train more younger people, let them understand what their challenges are. Because you're going to have a lot of challenges, and I know some young people don't like the challenges. It's tough. Yes, I done had a lot of challenges and stuff, but I stuck with it. So you have to have it in your mind and in your heart. This is what I want to do. Yes, they do need to get paid more. The challenge this weekend, I had to do 72 hours. I was called at the last moment to take this challenge on, which a client had lost her loved one, which was a caregiver. It was very challenging because it was a client that had Alzheimer's. And she kept on asking me, where is my husband? Which is Ron, was her husband. And so I told her, I said, Ron has left. He went to the hospital because she had got very upset from what another person had told her. So I said, look, it's going to be okay. I just put my arms around her and I said, look, Ron went to the doctor because he didn't feel well and he didn't want you to feel bad. So she calmed down and she said, okay. Okay, so dealing with challenging clients that have Alzheimer's and stuff, you never know, one day you might be in the same situation. So you want to treat them the same way as you want to be treated at any time.
Okay. The next is Judith Montague.
Aid for over 30 years. Hi to all. My name is Judith Montague. I've been a home health aide for over 30 years. For Home Care Partners, I am now a field counselor, which goes out and provides service for the elders, the young, the old. When the family have to go out on emergency, go to work, go to the doctor, and trying to get someone to come in to provide service for their parents, it's hard, it's horrible. The home health aides need more support, more financial In order to keep the home health aide happy and want to stay with the field, you're going to have to pay them more. We're the ears and eyes for the doctors, the nurse, the therapists, and so many other medical field people.
Next is James Kennedy.
My name is James Kennedy. I'm attended here at Capitol Hill Towers for 14 years now. And I'm here to answer the questions and give testimony concerning the need for additional healthcare workers. I'm a visually impaired person, and I do need the assistance in my home and outside my home by caretakers. I presently have a budget that would allow me to have a caretaker throughout the week, Monday to Friday and weekends. But it has been very difficult to get a weekend person because of the shortage of the healthcare workers there. The only time that I was able to have weekend assistance was one time in the 14 years that I've been here and have been dealing with health care. When I don't have a weekend worker, then I'm vulnerable to the environment. And on numerous occasions, I have either bumped my head on the freezer door of the refrigerator, the bottom door, and some of those knocks and bumps to the head were severe. I did sustain a concussion from a fall outside, and to continue to constantly hit my head is not a good thing. I do need that weekend assistance. I have an unusual healthcare worker Monday through Friday. She helps me
Okay. I think we're having some internet challenges.
through Friday. She helps me
Okay, I think it's doing the buffering altogether. Team, can we go to Miss Nolan? And we'll see if we can work on Mr. Kennedy's.
I am a member of one of the local DC villages and have been since 2009. My current medical situation has deepened what was a potential crisis before. I cannot, as my daughter said, manage right now and may not be able to manage with the various aspects of hygiene and other things that come up until one is mobile. I am not mobile. I cannot walk around the house. Yes, in the rehab facility, it turned out that because the facility lacked enough help, they had to pile additional patients. If someone didn't show up, they had to reassign the number of patients, and those of us who were patients therefore were in a wider field for one person to do all the hygiene and the medications and the transport. Was that one would wait 2 or 3 hours for the hygienic services. If you can't use the bathroom yourself, you have to wait. And they were so busy just distributing meds in that 3-hour block in the morning, they simply couldn't take the time to stop and do what needed to be done and the cleanup, and then separately serve the medications, serve breakfast, and handle 22 patients in a 3 or 4 hour block. And of course, it was difficult. They were lovely, gracious people working very hard. And sometimes they had to do a double shift because you can't really leave without anyone to replace you. Sometimes people couldn't or didn't show up. They're poorly paid, underappreciated. Higher pay might attract some people.
Okay. I think that was the end on that one. Team, can we try Mr. Kennedy again, or do we feel like that is?
And to continue to hit my head is not a good thing. I do need that weekend assistance. I have an unusual healthcare worker Monday through Friday. She helps me in the house to keep it clean. I'm a very clean person, and that I miss, she takes care of it. She also prepares my meals. I'm able to function in the bathrooms on my own, so we don't need that help there. But she has gone beyond the call of duty and have painted several accent walls in my house in an effort to help beautify the place.
Great.
It can go unbeautified because of my lack of the ability to see. It is important for the government to do all that they can to increase the number of healthcare aides to our aging citizens and those that are disabled and blind. However, we do need qualified assistants, so we would hope that they would get better training in those areas, those that are hired. And the increase in pay, I do believe, will attract more and more healthcare workers into the field.
All right. I'm glad that we were able to make that work. I wish that we had the opportunity to ask some questions, but overall, I'm glad that their voices were able to be added to this conversation. And I think also from the individuals who serve as home health aides, it was very distinctive. Everybody has almost nearly 20 years or more in sort of doing this work. And then, of course, the two stories shared by both Ms. Nichols and Mr. Kennedy of this work is difficult. It's not just physical in nature, but it also requires a certain amount of empathy for the client who had just lost her loved one, but didn't necessarily be able to fully understand that. And then also Mr. Kennedy talking about his aide who helped paint an accent wall in his home, which was very helpful. All right, so we're now going to go to the in-person folks. We have 4 seats here, and so when you come up, we'd love to get your testimony. So Kristen Ewing from DC Appleseed, Justin Palmer from the Hospital Association, Tina Sandry from Forest Hills of DC, and Sal Saveggio, who's the DC Coalition on Long-Term Care. All right, Kristen, when you're ready.
Good afternoon, council members Henderson and Bonds and staff. My name is Kristen Ewing and I am policy counsel at DC Appleseed. DC Appleseed is a member of the DC Coalition on Long-Term Care and chairs the coalition's workforce committee. The coalition's work is increasingly vital as the district faces a long-term care crisis. Supporting and investing in the workforce is crucial as it improves outcomes for consumers and families, workers and their families, and the broader community. A well-trained and adequately compensated workforce yields higher quality care for residents, resulting in improved health outcomes, including fewer hospitalizations, enhanced mental health, and a greater sense of well-being. Fully staffed shifts and facilities, as well as the ability to staff all home care shifts, also improve outcomes. Investing in the workforce can improve job satisfaction and retention rates. When employees feel valued through fair compensation, it can enhance productivity, reduce turnover, benefiting employers, employees, and consumers. We also need to recognize that 76% of DC's direct care workforce relies on some form of public assistance, with 56% relying on Medicaid. Increasing wages represents a proactive approach that leads to economic growth and improved overall well-being. A living wage offers a sustainable solution for long-term financial security, allowing families to invest in their futures. Higher wages can also lead to improved access to healthcare and reduced financial stress. It enables workers to thrive without having to work overtime or hold multiple jobs, allowing them to rest, care for themselves and their families, and participate in their communities. Improving outcomes for long-term care workers is also a racial and gender equity issue, as 77% of this workforce is female and 87% are Black or African American. A robust workforce also supports the overall healthcare system by reducing the use of EMS, emergency rooms, and hospitals, freeing up first responders, providers, and hospital beds for those in need. Adequate home care staffing also enables consumers to receive care at home when practical and desired, freeing up beds and facilities for those who require a higher level of care. Lastly, a sustainable workforce contributes to the economy by creating jobs, fostering a sustainable model of care, and stabilizing the overall healthcare system. There are several concrete ways the district can work to alleviate barriers to a robust workforce. Many are outlined in my written testimony. Today, I want to focus on wages. Low wages play a significant role in the workforce shortage. We are aware of the budget constraints ahead. Still, we must emphasize the district can choose to invest in workers proactively, offering higher wages, stabilizing the workforce, something in my throat, my apologies, and improving outcomes for both consumers and workers, or it can continue to reactively invest in workers through public benefits, perpetuating the crisis. The district is allocating budget dollars either way. One has more benefits. Last, DC needs a whole government approach to the crisis. Most importantly, we believe DC must identify and fund a person within the government to facilitate continuous collaboration and convening of all stakeholders. Given the many agencies and government entities involved, we must designate a long-term care coordinator to break down silos, convene the necessary government stakeholders on an ongoing basis, and serve as a liaison within the government and to non-government stakeholders. Thank you. I have submitted a more detailed written testimony, and I'm happy to answer questions.
Thank you. Mr. Palmer.
Good afternoon, Chairpersons Henderson, Bonds, and members of the committees on Health and Executive Administration and Labor. My name is Justin Palmer, and I'm the Vice President for Public Policy and External Affairs for the District of Columbia Hospital Association. Appreciate the opportunity to present testimony as Public Oversight Roundtable on strategies to support the District of Columbia's long-term care workforce. Meeting the workforce needs of the entire health sector has been a focus of the association and its members for many years. With the support of the council and the DC Workforce Investment Council, we established the DC Healthcare Workforce Partnership. The partnership is composed of healthcare businesses from three subsectors: acute care, ambulatory and behavioral health, and nursing, residential, and long-term care services. Core partners and network supporters. Healthcare employers lead the work by defining the agenda and driving it forward. Over the last 5 years, the partnership has focused on identifying workforce needs and in-demand occupations of our employer members. We started by identifying 5 in-demand occupations, and through the course of our work, expanded it to 10. At the center of this work has always been ensuring the needs of the entire sector are being considered, including long-term care. Certified nurse aides and or CNAs, as well as home health aides, have always been at the top of the list of in-demand occupations. The demands of these positions and the wages for them do present barriers to filling these positions. The Committee on Health has considered the funding requests, and the Department of Healthcare Finance continues to push for cost reports to ensure reimbursement keeps up with wages, though we know these efforts have not solved all the concerns. Beyond the wage piece, another solution is to ensure that career ladders for these positions are clear and opportunities for advancement exist to draw workers into the pipeline. Our goal is to create a system that allows individuals interested in having a career in healthcare to be able to start in an entry-level position and set a pathway to achieve their ultimate goals. Currently, there are 2 programs in the district being funded that help with this pipeline into healthcare. First is focused on young people interested in the field through the career and technical education programs, as well as the advanced technical centers. The students from the ATC have a leg up, graduating with at least 20 credit hours from Trinity Washington University, along with scholarships to complete a degree. Building on this work, we are collaborating with the Deputy Mayor of Education, OSSI, Bloomberg Philanthropies, and CityWorks DC on a bridge program for the students graduating from a health CTE or ATC program. The program, the DC Healthcare Employment and Apprenticeship Link, or DC HEAL, is stepping up to meet the challenge. Built on the foundation of the Bridge program, DC Heal is a strategic workforce initiative designed to create clear pathways to improve access to training and address critical staffing shortages in the healthcare sector. The second is the DC Alliance created by the Department of Employment Services, which we believe is a meaningful way of securing these training opportunities for adults as well. I'm happy to answer any questions. Thank you.
Thank you. Sandry.
Good afternoon, council members, chairpersons Henderson and Bonds. I'm CEO of Forest Hills of DC, Tina Sandry, the oldest senior living care provider in the district with 135 years of not-for-profit, mission-based, skilled nursing, assisted living, memory care, rehab, hospice, and respite services. I'm a licensed nursing home administrator, a certified preceptor, and a quality certified professional. I care about seniors and their caregivers. This is my life's work. We are a CMS 5-star consistently. A quarter of our workforce have been working for more than 20 plus years. We're great places to work, free parking, 0 out-of-pocket expenses for deductibles and copays for our employees, and we don't have enough employees. So we really need help in terms of these solutions. 4 out of 5 candidates don't even show up for job interviews. We need to, as Councilmember Henderson said, be able to retain our CNA schools and on-the-job training options for CNAs who often go home as single parents without the energy to go to school afterwards. So on-the-job is a really important aspect of access. In terms of the profession of long-term care, I would ask that you consider looking at the boards of nursing home administrators, which has now been absorbed under the Board of Nursing. But administration, social services, life enrichment, housekeeping, laundry, maintenance, grounds, rehab services, security, finances, dining services, human services, marketing, and admissions are additional areas besides nursing that an administrator is responsible for. So I think that is going to impact the future pipeline of administrators and the quality of the administrators that are coming out and leading these organizations. It takes a village to be able to care for the social supports that our long-term care workforce needs. I would suggest a creative idea. I realize it's not out of this house, but it takes a village to consider transportation credits like we give to our students after school hours. Our frontline caregivers might be able to benefit from 10 free rides a week to get to their jobs because we know most of them don't drive cars and can't afford parking in DC. We also need to citywide look at, as has already been mentioned, the mental health of our workforce. So the U.S. Surgeon General has reported that the mental state of the healthcare workforce coming out at COVID is at a crisis level. It's an 80-some page report. And along with understanding that healthcare career is a destination, that we should also be looking at combating ageism and supporting the fact that old people are really cool. And so the mayor's office and the council have repeatedly looked at supporting that concept and how do we broaden that across the city. We need tort reform and caps on legal cases. Currently, there are no caps, which make it hard for long-term care providers to procure and pay for insurance to operate in the district. I have a much more detailed report, including ideas on our CNA apprenticeship program, which specializes in dementia, end-of-life care, and leadership, and I'd be happy to answer any questions.
Thank you. Sal?
Thank you, Councilmember Bonds and Henderson and staff for the opportunity to provide testimony concerning strategic planning on the critically important healthcare workforce issue. When I was considering what to say in this testimony, I thought back when I first became aware that there was a problem with the status of this workforce. It began when my parents required help to remain in their home as their health declined. The home care aides needed to provide help with activities of daily living were sometimes not available and varied widely in their skill level and interest. Later, when I was a practicing dentist over my 35-year career, I witnessed the change in health of some of my patients as they grew older. Some lost their ability to self-care because of physical or cognitive problems. Many required aides to help to safely transport them to my office and provide home care for their oral health, which affected their general health and well-being. The children of these patients would sometimes tell me of the difficulties in finding an available, competent aide to help them with their parent. They expressed their anxiety of dealing with the stresses of their own lives while worrying about the quality of care their mother or father was receiving at home while they were at work or when their parent was in a long-term care facility. After my retirement, in part because of these experiences, I joined the DC Coalition of Long-Term Care. It has been inspiring to be a part of an organization that has been righteously relentless in seeking to address our healthcare workforce shortage. Healthcare workers, their employers, unions, villages, recipients of care, and others have coalesced to help solve a very complex problem. This has been for me a model of effective citizen action. I have been working with the coalition to provide video testimonies to the council by interviewing individuals involved with each aspect of our workforce shortage. The takeaway for me is that the entire system of recruiting, training, certification, licensing, regulation, and deployment of the workforce cries out for intelligent coordination. The various DC governmental players, such as the DACL, DHCF, DC Health Board of Nursing, Mayor's Office, and others, need to be guided by a plan. This plan should have an entity with the authority to coordinate these players to put into motion a practical course of action to ensure that the aging and disabled individuals residing in our community can receive the quality care they need when they need it. Trying to manage the many needs of our city in times of austerity is, to say the least, challenging. I don't envy our governmental leadership. We should, though, look at these times as an opportunity to reimagine the processes and regulations that could sometimes create barriers and stumbling blocks to progress. I have faith that with determination and goodwill, our home care workforce shortage can be successfully addressed. We really don't have a moral alternative.
Thank you to this panel of witnesses. Councilmember Bonds, are you okay with 7-minute rounds for the public witnesses? Okay, wonderful. Okay, I don't know really where to start. There's so much information here. Justin, I think I'll start with you. So OSSI shared in their testimony that they're piloting a new initiative this summer, which will provide CTE concentrators enrolled in a non-CNA health career pathway with the opportunity to earn their certified nurse assistant license during the summer after they graduate, as part of this partnership that they're doing with the Hospital Association. How many individuals do you all have funding for this program?
I have to get the exact number. I think that there are about 16 slots in that cohort. There are
And
2 cohorts.
2 cohorts.
But it's 16 total.
16 total. Okay. When are you all planning to start the recruitment for this initiative?
Odyssey should be starting that soon. I think what the way that came out was the bridge program that I mentioned. Because of the regulations on the age piece and some of the other opportunities, not all students in that CTE programs that are like, they don't go to Coolidge and they don't go to the ATC, don't get that program. And so what the idea for that summer program came about we have CNAs as a base requirement for that bridge year and to provide everyone that opportunity if they didn't have that. So it's really, we've been working with the CTE leads at the schools, and they're identifying students that are interested in this program to be able to get their CNA by the end of the summer, so they can participate if they want in the DCEL program.
Okay, that's great. I feel like we need to be doing more of this. I was kicking around this idea with my staff and reached out to OSSI of, okay, we lowered the licensure age for CNA to 16 because we had a couple of LEAs who had expressed interest. Great. All right. How else do we build out these pipelines without spending any ridiculous amount of additional funding? So, the ATC, the Ward 5 location is built out for nursing training. What would happen if we had the ATC as a summer youth employment site? And so students who are interested in doing their CNA licensure training over the summer, and then they get paid through SYEP through their wages. Here's another group of maybe 10 or 15 students who at the end of the summer can now sit for the exam because they are the right age, right? And then they're coming into the pipeline. So I feel like I don't think it's necessary for us to spend an inordinate amount of new money, but we just need to retweak the programs that we already have to address the workforce issues.
That coordination, I think, is key of how do we layer the money and braid it in order to get the most bang for the buck. We have the ATC programs, we have UDC, WDLL, and how do we get those programs all tied together? So you have the programs for the young adults, and then also for the older adults to make sure that they're tied into the programs that they can get it over the summer, but then also I think the other part of that is to focus what is next and how do we help get them to their next level if they want to. I mean, if people want to be CNAs, that is perfectly, but how do we also to address some of the problems, that was mentioned of, Trinity now has a part-time nursing program, which is wonderful. And how do we look at making the advancement achievable to get, these are desirable jobs, because I know I can, it's a pathway for
Oh, for
career.
sure. And I think that is what we need to do better in sort of talking about what is the career ladder pathway. I think we had a witness who testified last year who talked about how she got her CNA, then went to nursing school, then went back and, got her doctorate, and just sort of like build up. There was another witness too who said, I think she went to undergrad in Georgia and had her CNA license, and like working in a nursing home was her part-time gig, right? And so you have friends who are working at they're doing work study at the library or something like that. And she was working using her license to be able to, earn in that way. Miss Sandri, I actually wanted to come to you. Can you discuss a little about how you all developed the apprenticeship program at Forest Hills?
Yes, so our apprenticeship program started in '22, and to date, we have 17 apprentices who have graduated. 16 are still working as a CNA apprenticeship. And as I said, our program specializes in dementia, end of life, and leadership. And so the team that put this together actually did a similar thing about a decade ago within the Magnet program for nursing homes. So my teams worked with me in a model similar to that. And we had some grant funding through Department of Labor, DOES. So putting those dollars together, we then were able to recruit DC residents who were existing CNAs within our community already, because Plan, Do, Study acts small and then grow it out. So we started with an initial cohort of 5 to just sort of run the systems and the paperwork and so forth to kind of make sure we were processing correctly. Since then, we've had a number of other cohorts as CNA apprentices. And we then, when they finished their 10-month training program, of which about 70% of it is on the floors, on the job during the day training, and then the rest is classroom, hands-on kind of scenarios as well, then they are able to sort of be mentors to other program, and they help sometimes to interview other future candidates. So it becomes a cycle of mentoring and teaching and encouragement throughout the community where we have this. So Forest Hills is the sponsor. Summa Prime is the actual school. And so we partner and hold hands together in that way. And we go to organizations and say, this is what we want to do.
Okay, let me ask you one other question before my time runs. You mentioned something else in your testimony that hasn't really been talked about before, which is tort reform.
Yeah.
Can you say more about that?
So in DC, there isn't a cap on medical malpractice and suits. And so the lawyers around the area do know that DC doesn't have caps. And so they will chase after cases. And because there is no caps, the communities that are well insured for their practices then become targets for malpractice cases in that regard. So it would be good if council could take a look at tort reform for long-term care in particular in that area.
Okay, thank you. Councilmember Bonds.
Thank you all for being here, and you're very interested in your testimony. But I must say, I want to start with this issue of how do we pull all these pieces together so that we have a health program that will, yes, benefit our residents, those who need the care, as well as those that are looking for work. And how do we make sure that it's a process that is dependable? Because it sounds like we are in many different places, and I think we ought to be pooling our money so that we can get a big bang for the buck. And I know in talking with Justin in the past, there's been this issue of finally getting the attention of one or two of the agencies so that we now have this quote unquote alliance. But is that the process that we all can fold into to know, for instance, the number of training programs that we currently have? I don't think we really have that information at our fingertips at this moment. And so it just seems to me, if we're talking health, and it's a huge arena, as you mentioned, for sure, Ms. Andre, but how do we really begin to take advantage of this service that is going to be needed for decades to come, and certainly now? And I wondered if anyone has any idea of where we start. And I wondered if Dr. Salverio would want to explore, where do we start? How do we get this plan done?
Oh, thank you. By doing these interviews, I was talking to kind of every stakeholder in the process. I interviewed the training centers, interviewed the workers, and interviewed the recipients of care. At Home Care Partners, I interviewed Eric Benna, who was involved in recruiting. And the interesting thing was that they have many, many people who are interested in these jobs, but unfortunately, many of them just aren't qualified. So then when I spoke to the training centers, I asked, what are the impediments to the pipeline process? Why aren't people getting through? And everyone I spoke to said they had people who were interested in the jobs, but then when it came to the credentialing process and then the licensing process, sometimes they had to wait weeks or sometimes months. And there's many reasons for the hangups, including not enough nurses in the credentialing, the entities that's doing the credentialing in order to certify these people are qualified. And then also just the paperwork and getting the licensing. So if you're someone who is of low income, you need these jobs, and you see there's this much of a wait, it's a disincentive to go into this field. So I would say, looking at the roadblocks, the areas where there's blockages, and then looking how to make those blockages go away or at least reduce.
I certainly appreciate hearing that. I'm thinking too, do we have a process for mapping out the need of the different types of health-related services, mapping them out so that we can say, all right, I think one of the areas we all talk about is home care aides. And we think about the senior population as it's growing. We know how many are currently engaged in homes and helping those that are aging at home. Do we know what it would look like 5 years from now? And can that help us to plan for the number of home aides that we would need into the future? And then we work on the licensing and all of those items that we need in order to have a well-trained body of individuals that'll work in this field.
The DC Coalition on Long-Term Care has done surveys of employers to get that kind of information. I don't have that at my fingertips, but I think the coalition will be able to provide you with that kind of information.
All right, I appreciate that.
Do you mind if I
Yes,
jump in?
yes, please, Ms.
I also
Owen.
want to say the Certified Nurse Aid Amendment Act, which was passed and DC Health has been working to implement, will combine the licensure for the home health aides and the CNAs, which I think will help address some of that because people can work across both of those areas. So you're not tied to only one, and you don't have to go back and get training, which we know can be an impediment for people that don't have the time or the money to go back and get that other training because maybe there's more jobs in a CNA position right now. So I think once DC Health has finalized that process, that will help alleviate some of these issues where we have gaps, in one area versus the other, and will help as we have an aging population that we're unsure, will they need care at home? Will they need care in a facility? And I think, passing that bill, and thank you to the council for doing that, is a big step in moving towards that.
I would recommend that we consider the option, or the council consider the option of taking a systems coordination approach. And in the words of, I forgot Sam's last name, our esteemed new head of DOH, he actually spoke with all the long-term care, senior living, skilled nursing, and assisted living providers, is having someone lead the team charge who has a systems-oriented approach with an eye on quality. And the Baldrige framework for quality is well known. It's been used in healthcare, and in fact, the Baldrige Quality Awards in America, more awards go to healthcare organizations than anywhere else. So you can see it in motorcycles and other cross industries. And it would be such a cool, unique challenge to take that Baldrige approach and layer it over DC's healthcare system as opposed to one organization. So my organization is already certified at silver level. We're moving towards gold. And it's really an elite level of quality that provides a systematic way to coordinate. And you have somebody on your team who has a really good systems orientation.
Thank you. I'm out of time, but this has been so rewarding because this is where my head has been. How do we, and I didn't want to suggest it, but I will put it on the table for my colleague. I really think we need a coordinating committee that will look at this with timelines, et cetera, so we can really move forward expeditiously. So thank you very much to the panel.
Thank you. Thank you all. If you haven't given us your testimony, please make sure you upload it for the record. Okay, I'm going to go to the next four. Holly Eaton, Angela Fisher, Jacqueline Caby, and Marla Lahat. Great. All right, Holly, when you're ready.
Thank you. I would like to thank Chairperson Henderson, Chairperson Bonds, and the DC Council for holding this joint roundtable to discuss the very serious issue. I'm sorry, thank you. This very serious issue of home health professional needed to serve DC's residents receiving long-term care. My name is Holly Eaton. I am the senior attorney for the DC Long-Term Care Ombudsman Program with Legal Counsel for the Elderly. We are celebrating our 50th year, serving seniors in the district. The focus of today's hearing is engaging in a dialogue regarding solutions to the shortage of health aides and nurses adversely affecting DC residents receiving long-term care. However, while working to expand our long-term care workforce, I want to highlight a problem that is exacerbated by this shortage to the extent to which you may not be aware. And that's the vulnerability of individuals involved and the fact that we have enforcement mechanisms in place that are not being used. I will also address the need to opt into 1915J to expand the availability of PCAs, private care aides. The situation that I wish to address is EPD waiver beneficiaries who are approved for 24 hours of PCA services who do not receive the hours they are entitled to. During the pandemic, when home health agencies first started experiencing staffing challenges due to the shortage, DHCF temporarily authorized agencies to pay PCAs overtime, making it easier for them to fully staff their 24-hour cases. It saved a lot of lives. Following the pandemic, however, these agencies have not been living up to their obligations to provide services, leaving these particularly vulnerable beneficiaries at risk of serious injury or harm. Because of the shortage of PCAs, the home health agencies are allowing aides to cherry pick the easier cases and effectively abandoning the difficult ones. The 24-hour cases are, by definition, the difficult ones. These individuals are bedbound, often as a result of stroke or spinal cord injury, often unable to feed themselves, are incontinent, require repositioning every 2 hours, diaper changes, regular cleanups. But the problem isn't just the workload. If the beneficiary is able to articulate his needs, ask for assistance, and oversee what the PCAs are doing, the aides do not want to return to that job because they object to being told what to do, and don't like being watched. The same thing happens to homes with a family member overseeing the care of a loved one, unable to articulate their needs. Family members often know exactly what their loved one needs and what they are trying to say when attempting to express themselves. It is very common for aides to refuse to return to such jobs because they don't appreciate being supervised. In some cases, family members monitor their loved ones' care remotely with video cameras, and aides specifically will refuse to return because of the presence of video cameras in the home. Home health agencies allow their aides to refuse these cases because they know the aide can easily find work at another agency that will let them choose easier cases. In addition, is a very serious problem of aides showing up with no intention to work the entire shift, and this is overnight, and that's what most of these 24 cases are dealing with. Many of my clients report and have photos of aides arriving for the overnight shift, midnight to 8 a.m., with blankets, pillows, hair rollers, clearly intending to sleep. When the beneficiary or family member expresses alarm and insists they remain awake to provide the care and monitoring they're being paid to provide, the aide refuses to return to the job. Some, not necessarily all aides, would prefer to care for patients who are docile, perhaps in cognitive decline, who are not going to supervise them so they can do whatever they want, of course, with no one at home and no video monitors. I have learned there's a term for these cases among aides. They are called free cases.
Miss Eden?
Yes.
You're about a minute over your time.
I'm sorry.
If you want to wrap up, and then we can
Yes.
certainly will ask questions.
I will have much more in my submitted testimony. I just wanted to mention that the 8 hours need additional coverage when no health agency will take the state plan care hours. And that is where the 1915J would allow DC to use Services My Way to cover those 8 hours. And that will be the only way in some cases that these individuals will get the care they need. Thank you. I'm sorry.
Thank you. Angela?
Good afternoon,
Oh,
Chairwoman.
Angela, you got to turn your mic on.
Good afternoon, Chairwoman Henderson, Chairwoman Bonds, and members of the DC Council. My name is Angela Fisher. I'm a sister and power of attorney for my brother Charles Fisher, who is a resident of DC and an EPD waiver beneficiary. This is not the first time I've brought this issue to the Council's attention. Last year, I raised issues about the abandonment of my brother by the home health agency that was supposed to provide services to him at that time, and refused to staff after abruptly suspending personal care aid services. My brother suffered a massive stroke in January of 2019. He has been bedbound ever since. He is authorized to receive 24 hours of personal care aid services. For the first four and a half years, he received 16 hours of PCA services from 8 a.m. to 12 midnight from Burhan and 8 hours of overnight services by MBI. In November of 2023, one of his longtime Burhan aides physically and verbally abused my brother, which had been going on for quite some time. I observed it remotely on the video camera in his room and recorded it on my phone. I called the police and he was arrested after attempting to run from the police. Within days, Burhan Home Health Agency notified me that they were suspending services because the 2 aides that had been providing services were no longer available. One they were unable to reach, and the other one that had been arrested for abusing my brother. For over 6 months, while the case dragged on, Burhan provided no services whatsoever. Over that period, without sufficient care, my brother was hospitalized 9 times. I eventually had no choice but to sign my brother up for Services My Way, which took a while to set up. I ran into delays getting the participant directed workers in place. On December 4th, 2024, almost a year to the date after Burhan was allowed to abandon caring for my brother, MBI, the agency covering the overnight shift, took a page out of Burhan's playbook. This time, I was the one assaulted by the aide, not my brother. In an unprovoked assault, the aide hit me on the face with her fist and cell phone multiple times, causing bruises, 2 black eyes, a severed upper lip, a busted lower lip, a knot on my head, 2 loosened teeth, bruises and scratches on my arms, bruises and injury to my right and left clavicle, and a concussion, which landed me in the emergency room. She was arrested and her license has been summarily suspended. Shortly after the incident, the agency notified me they were suspending services out of concern for their aides. I learned afterwards that the aide had been arrested for domestic violence in February of 2024, a year and a month prior to assaulting me. She was arrested again a month after the arrest for assaulting me and charged again with domestic violence in her home. Agencies talk amongst themselves. So this precedent of abandoning vulnerable 24-hour beneficiaries is now seen as a viable way for them to get rid of cases that require aides to do work and are not able to sit and sleep. This cannot be allowed to continue. If MBI is allowed to drop my brother as a client, he will have no options available to him whatsoever because of the current requirement of 8 hours of PCA services must be provided by a home health agency. I would like to be able to fill that shift with a PDW under Services My Way, but DC does not currently allow this option. I'm here today on behalf of my brother to ask the council to, 1, require the health department and DC Healthcare Finance to hold these home health agencies accountable. If they take a case, they must provide services. If they suspend services for no good reason, they should not be allowed to receive referrals for new cases until they have fully staffed the cases they accepted. And 2, expand the ability of the EPD waiver beneficiaries to staff their own cases through Services My Way for the full 24 hours, since we are at risk of having no coverage whatsoever where home health agencies are allowed to abandon the most vulnerable residents of the District of Columbia. I would be happy to answer any questions.
Thank you. Ms. KB, if you need to step out for some water, I can go to Ms. Lahat and then, yep, all right. Ms. Lahat.
Good afternoon, Chairperson Henderson and Chairperson Bonds. I'm Marla Lahat, and I'm Executive Director of Home Care Partners, a nonprofit home care agency, a proud member of the DC Coalition on Long-Term Care, and the very proud employer of 4 aides that you saw on the video, and Ms. Jackie Cabay, who you will hear from shortly. In DC, our home health aid services to older DC residents and adults with disabilities are funded by both the VA and by DACL. We're also funded by DACL for the Caregivers Institute and the Safe at Home program. Our Homemaker program through DACL provides 3 to 15 hours per week of home health aid service. Yet the workforce shortages have made it difficult for us to staff even those modest amounts of care. You both led with all the problems that we're facing. I'm not going to repeat them all because you certainly know what they are. Shortly, you'll hear from my colleague, Jackie Cabay. I'm not going to steal her thunder, but Jackie is a licensed home health aide who has now been promoted to the position of scheduler at Home Care Partners. And she will tell you a little bit more about that. The DC, the CNA Amendment Act of 2024 is a fantastic first step. We need to implement the provisions of that amendment, and I am really thrilled that the advisory committee met for the first time yesterday. So hopefully we are making good progress in that regard. In addition, I would like to emphasize that we do need more free training programs, free and accessible training programs for those who want to enter this field. At Home Care Partners, very, very often, we put ads in different platforms. We get more responses than we can count. About 90% of them are not even qualified. We cannot consider them. We need the training schools to be able to train these workers. We also need the wage increases. And I think there's not a person in this room who doesn't know what's going on with the federal and the DC budgets. But you heard yourself, these positions do not pay enough for the type of work that is being done. At Home Care Partners, our average wage is about $21 an hour, which is probably more than many other agencies. And yet the workers you saw in that video who have been with us 20 plus years often make the same amount as those who are with us only a short period of time. We also need more diverse career paths. Jackie's going to tell you more about her job as scheduler. The career path to nurse is wonderful. It is not the only career path. At Home Care Partners, we have home health aides who are working as schedulers in human resources, as receptionists, in payroll. These are important positions as well. I know my time is up, but finally, I do want to commend you for holding this roundtable. As was said before, we need a coordinated effort. We need somebody who can be in charge and look at the entire program and the problem that we're facing. Thank you.
Thank you. All right, Ms. Cabay.
Good afternoon, Chairperson Bonds and Chairperson Henderson and other roundtable participants. Excuse me. My name is Jackie Cabay, and I am a scheduler at Home Care Partners. I am also licensed in DC as a home health aide. I would like to tell you about my personal experience and how the shortage of direct care workers have impacted my work. When I started my career as a direct care worker, I was first licensed as a CNA and worked in nursing homes. However, when I wanted to take the job in home care, I had to go back to school and get a home health aide license because my CNA license wouldn't allow me to work in home care. I was able to take the free home health aide training program at OIC, DC, and that program no longer exists. After getting my HHA license, I went to work at Home Care Partners. I loved my job, but when I tried to get a second job at a nursing home, I was no longer eligible because I had let my CNA license lapse, and my HHA license was not accepted in nursing homes. In my 8 years as a home health aide at Home Care Partners, I saw how challenging the job can be. You have to do work that can be difficult, such as doing personal care for a person or client who may not realize they need it, and doing light housekeeping in homes that may be cluttered or unsanitary. You have to deal with different personalities and clients and their families. You also have to travel to clients in different parts of the city, often taking buses in bad weather for visits that only last 3 hours. You may have a gap in your schedule and not get paid when clients are in the hospital or even cancel services for the day. Home Care Partners offers several promotional opportunities, and I am grateful to have been promoted to the job of scheduler in 2023. In this job, I am responsible for scheduling 32 aides and over 100 clients. I work in the office and have a consistent 40-hour week schedule with regular pay. However, now I see the workforce shortage from a different perspective. Simply put, there are not enough licensed home health aides. Some leave the job and go to work at other kinds of jobs that don't require a license, travel, and uncertain schedules. Some aides work multiple jobs, so their availability is limited. Some have very specific preferences and are only willing to work in certain areas of the city and at certain times. In my 8 years as a home health aide, I saw how challenging the job can be. You have to do work that can be difficult. Did I read that already? I'm sorry. That's okay. We need to address these problems. We need free training schools available for those who want to do the important work. The home health aide and CNA licenses needs to be combined, and because the skills are the same, and it's only the setting that is different. Licensing needs to be easier, especially for aides who have experience already and a license from Maryland or Virginia. Direct care workers deserve higher pay for these very critical and challenging jobs. Thank you for the opportunity to speak today, and I'm happy to answer any questions.
Thank you so much to this panel of witnesses and all the various issues that you brought to the table. Ms. Cabay, thank you for your testimony and for your dedication to this profession. To your point around what happened with you of you had a CNA, you wanted to work at home, then you had to go back to school to get this other license, and then the license expired when you were trying to go to do a part-time. We passed legislation to combine the two because we noticed that individuals might want to go back and forth between working in a home setting or working in a facility. And while some of the requirements are different, they're not that different to force someone to have to do an entirely new program all over again. But it is great that you were able to experience a free program, but you said that training program no longer exists. Okay. Okay. And I think also something you brought up too that I hadn't necessarily thought about, which is what happens if a client is in the hospital for someone who's assigned to that person. That's a period of time I'm assuming you're not getting paid.
Well, now as a scheduler, I've been seeing a lot of those challenges with my aides. They lose out on pay because there's not another backup client to go to. And the clients may go into the hospital, it could take weeks, and I've seen some months. And also, if a client may not need service that day, they'll counsel out and say, hey, I don't need my aide for today. Well, that's also losing out on pay.
Because there's not like you could just reassign them to someone else.
Right.
Okay, that's a interesting thing that we haven't necessarily thought of yet, but thank you for being here. Ms. Lahat, thank you for being here as well. It's good to hear that the advisory committee has met already for the first time. We've tried to put some pressure on DC Health of, there's some things that we included in that legislation that was at their request, and we want to make sure that we're moving ahead on some of these fixtures, because I don't want to be here in a year where we're still talking about implementing some of these licensure changes that we've already put forward. Ms. Eaton, in your testimony, you talked about the 1915J waiver. I feel like this came up last year. We did ask DC Healthcare Finance about that, and they are looking into it. One of the things I had a question for you about, though, was what are the efficiencies that could be gained from if we were approved for a 1915J waiver versus Services My Way? Oh, I mean, turn your mic on. There you go.
Sorry, and I just realized that there's a timer over there, which I didn't see before, so I'm sorry about that.
Okay.
1915J waiver, and there's also a 1915I waiver, but what's different about J is you can limit it geographically, which doesn't affect us, but to certain cases. So you could say that it was everyone over 16 hours, for example. So it wouldn't have to necessarily be everyone. You could do it as a pilot just to see, does it work? Is it working? And what it does is allows those who would like to have aides at all, because they're not getting aides for those 8 hours, because they have to get 8 hours from one of the home health agencies. And once you are discharged by a home health agency, nobody will take you because they talk. Why did you get discharged? There must be a reason.
Mm-hmm.
And so it's impossible. And I'm dealing with it right now.
Well, I mean, Ms. Fisher,
Yes.
in your testimony, brought up that exact case. And first, let me say, I'm incredibly sorry for what happened to you and your brother. No one in that situation should ever have to face assault in their home from someone who presumably was hired to help. And, the concern that you raised about the abandoning of 24-hour cases, I think from all of the testimony, the 24-hour cases seem to be the hardest in terms of staffing. Is the ideal that it's one person for the entire 24, or could it be broken up in terms of 12 and 12?
No. You can, it can be, frequently it's 8 hours, 8 hours, and 8 hours. I mean, it can be broken up. That's not a problem. It's just 16 hours have to come from one source, whether it's Services My Way or a home health agency. And the other 8 hours, which is the state plan hours, have to be another home health agency. So if you were to do Services My Way, you would have 24 hours. You could break it up any way your aides wanted to. You could do 4 hours and 10 hours and what have you, whatever your aides would want.
But even in that particular case, for instance, right, there's no requirement that the state hours come for the 8 to 2 a.m. or the
Correct. That's correct.
The later portion. So, Ms. Fisher, I'm wondering if you could speak a little to what your experience was like trying to find someone under Services My Way.
It was very challenging because I didn't know anyone in particular who was interested in doing the work. The young man that I have now was referred to me by GT Independence. He was one of their workers.
It was GT Independence, another agency, or?
That's the Services My Way contractor.
Got it. Okay.
Yes. And he had a client, which was a family member of his. That client passed away, and his family member, and he put his name on the list as being available to take on a case. The issue with Services My Way is that it takes a long time for them to go through the onboarding process. I'm not sure why, but it takes an astronomical amount of time. So that's always, that's always been a challenge as well. And
Okay, because that's always been my sort of question, as we've heard from individuals who have testified about Services My Way, is what is it about the Services My Way program that makes it easier for you to find someone than going through the agency or the traditional method?
Well, I hope I'm answering your question. The problem that we're having specific to my brother right now is that he is awarded 24 hours from Liberty. He's supposed to be getting 8 hours from one agency, 8 hours from the second agency, right?
Mhm.
And then
16.
the Services My Way, 16 hours. But both agencies have bailed on him. And now I'm afraid that he's not going to be able to get services at all. The first time was Burhan because their aide assaulted my brother, as I testified here. The second time, NBI did the exact same thing, stopped giving him services because I was attacked by an aide. So now we have no one, and I've been carrying the burden of taking all those hours, doing as much as I can alone.
Okay.
I know you're out of time. I just wanted to quickly say that in some cases, there are family members who can step in, and that's what's happened for those who've lost those 8 hours overnight because no home health agency would staff them or were too much trouble to deal with.
Right, but I think Ms. Fisher's, her situation is a little bit different. We're not just talking about
yeah, she's-
overnight. There's another gap.
Yes.
That is occurring there too. Another 8 hours in addition to the overnight piece. That is supposed to come from two agencies. Okay. Healthcare finance isn't here today, but that's definitely something that we can certainly follow up with them on. I appreciate that the agencies have some quote unquote agency, but what happens when everybody says no, but they're saying no, not for a particular grounded reason, but just from, oh, this family is difficult, so we're not going to do it.
And can I speak on that for a moment?
Sure.
I'm glad you brought that up because that is the scenario where they label you difficult. Difficult means that there's someone in the home who's able-bodied and able to articulate and monitor things and make sure that everything is going well in the home, or you have cameras in the home where you can monitor remotely. They don't want those cases. They don't want to work in those conditions for whatever reason. It's and they communicate to one another, say, oh, don't take that case. They have cameras, so don't take that case because he has a sister there, and she'll tell you don't do this or don't do this. You can't sleep, you can't lay on the couch, and that kind of stuff. And it's unfortunate that they come with that perspective, to not do anything because I wasn't always at my brother's place. I was in my own home, and he had the services in place until he was assaulted by the aide, and the bottom fell out of the whole thing. I was forced to be there, and now when they were sending aides, and they would come for one night and realize someone was there to hold them accountable or just be there present, they didn't want to come back.
Okay, I'm over my time. Councilmember Bonds.
Thank you all very much for your testimony. I guess I'm sitting here wondering what it will take to, or maybe we already have a process in place where family members can be certified to do this work. And I assume that's My Way is the acronym that we're really using for that. I wonder if that is not a way to look at the circumstances that we're faced as we're going to have more and more older folk that will need a little tender, loving care. And I wanted to ask if any of you talked to DACL about their caregivers program, if you had any discussions with them.
I'm not aware of.
Yes, anyone who has had any discussions with them.
Thank you, Chairperson Bonds. Yeah, Home Care Partners actually has the grant for the DC Caregivers Institute through DACL. And many of those caregivers are caring sometimes 24 hours a day for their loved ones. But unless you're in the EPD waiver program, you can't qualify for services my way. That's specifically an EPD waiver program. Through the Caregivers Institute, we do offer various respite options to give those family members a break. But even there, the workforce shortage enters the picture, because if there aren't enough aides to provide respite, then those family members often have to fill in the gaps.
All right, and so you're sharing that one of the situations we're faced with is to figure out how family members can qualify for the waiver program. Because I know many of our folk who need help in their home are, those that also qualify for the waiver.
Yeah, it would
So we
be
need to
the,
find a way that we
the
can.
care recipient, the care
Yes.
receiver would have to
Yeah, the
qualify for the
receiver.
waiver
Yeah.
program.
Yeah, I think that's something that we really need to look at. And I'll be talking with DACL a little bit about how they can be a part of that. So thank you. Thank you very much. I'm very sorry to hear that it's difficult, but my mom, she had a caregiver, but I guess she, in her journey, it was quite interesting. She felt she didn't need it, and trying to convince her, you're falling all the time, you do need it, that kind of stuff. So, it's, in other words, there's more friction than we really realize. It is about the mentality of those who receive the services, as well as those that have to try and get compliance for the best. So thank you very much for your testimony.
I just wanted to say there are some absolutely fabulous caregivers. I don't mean to disparage. There are some that Angela's had that have been wonderful. So
Yeah.
I didn't want it to sound like
Yeah,
it was only one
sure.
kind.
Yeah.
Thank you.
No, thank you all for your testimony. Thank you for being here. Okay, I think this next panel might have to be split depending on who's here. Is Veronica Faison, okay? Paola Henriquez? No, okay. And I don't see Commissioner Ruff. All right, so we're gonna also go to the virtual folks who are on as well. Rachel Ellison, Jake McDonald, Rajon Thomas, and April Young. And for those who are joining us virtually, you'll have to affirmatively accept our invitation to become a panelist. All right. I have to step away to make a statement in another hearing. So Councilmember Bonds will continue on, but Ms. Faison, when you're ready.
All right.
Good afternoon, Chairperson
afternoon.
Henderson, Chairperson Bonds, and everyone in this room right now. My name is Veronica Faison. I'm an attorney with the National Women's Law Center. I'm incredibly grateful for the opportunity to uplift the issues direct care workers face while providing residents with the long-term care that they need and deserve. Just a little bit about the National Women's Law Center. The Law Center has fought for gender justice since 1972 in the courts, through public policy, and in our society, with a particular focus on the needs of women of color and women with low incomes, as well as their families. Now, direct care workers, who are predominantly women of color, support disabled and aging people as they navigate their lives, helping them meet personal or healthcare needs in long-term care facilities or in their homes and communities. But as many of us have talked about today, direct care workers are undervalued and underpaid, making the work incredibly unsustainable, despite the fact that thousands of people rely on their support and services. Like many professions where women of color and immigrants are overrepresented, direct care work is characterized by low wages and very few benefits. With roots in chattel slavery, where enslaved African women provided unpaid care to white children, care work is still largely historically undervalued in the United States and relies on the continued exploitation of women of color and immigrants. In DC, nearly all of direct care workers are people of color, and 77% are women. Nearly half are immigrants. Direct care workers often do not make enough to be secure. Annually, direct care workers in DC make a median wage of $34,000, an income that does not stretch very far in a high cost of living city. So as a result, nearly a third of direct care workers in DC live in low-income households. Across the US, this is also the case, where almost nearly half of direct care workers rely on public assistance, including Medicaid and SNAP, simply because their wages are insufficient to survive without it. This low pay makes it difficult for direct care workers to do their important work and also take care of their own families themselves, contributing to the inequities working Black women face in the US and in our city. Like so many women workers, direct care workers have caregiving responsibilities as well. Nearly 30% of home care workers, for example, live with children under 18. 30% are also unpaid family caregivers for an older adult themselves, like their aging parent or their disabled partner. But women direct care workers who are supporting their families face a very high risk of poverty. Nationally, women direct care workers with children under 18, for example, have a near poverty rate at 40%, which is nearly double that of women direct care workers that don't have children, for example. In DC, where a lot of direct care workers are Black women, the gender and racial wage gap is incredibly steep. Black women working full-time year-round in DC are typically paid an average of 50 cents for every dollar paid to their white non-Hispanic male counterparts. This is one of the largest wage gaps in the country. While Black women obviously face multifaceted systemic barriers, ensuring that direct care workers have a living wage can help chip at the gender wage gap that stems in part from low wages in occupations like direct care work, where the critical labor performed by women of color has been undervalued for generations. This lack of a living wage ultimately drives direct care workers out of the profession and brings very few people in. As a result, people's access to quality long-term care is precarious and deteriorating. Low wages and minimal benefits make it hard for direct care workers to stay in their jobs, thus driving up turnover. But turnover can also decrease the quality of care people receive and create bad working conditions that drive even more people out of the workforce. When workers are spread too thin, trying to keep up with the gaps in coverage caused by turnover, recipients of care can go without the attention they need, increasing the risk of injury to both the recipient of care and actually the worker themselves too. In 2021, a national study found that the average annual turnover rate for nursing staff in nursing homes was over 120%. And as the council has noted, in 2023, nearly 4,000 CNAs and home health aides did not renew their licenses to work in DC again, a loss of 30% of the workforce here. This alchemy of inadequate compensation and poor working conditions have caused a national shortage of direct care workers that obviously we feel in the city. In DC, there are 11,500 direct care workers, yet 36,000 people need the long-term care that they provide, meaning that there are many DC residents that are going without care that they need to navigate their lives to the fullest. This crisis threatens to obviously only get worse without further intervention. As noted, by 2030, the older adult population in DC could increase. Ultimately, the Law Center supports efforts that make it easier for people to provide long-term care in DC and support their families, like the continued implementation of the Nurse Aid Amendment Act that would help scale up wages and benefits and also reduce the barriers for people to enter the profession. Direct care workers are people who deserve to have their needs met so that they can take care of themselves and their families and to support the disabled and aging people in DC who deserve to live dignified lives. Thank you so much for your time.
Thank you very much for your testimony. And now we'll hear from Ms. Enrique.
Yeah, thank you. Hello, thank you for the opportunity to testify today. My name is Paola, and I'm the DC organizer for Hand in Hand, the Domestic Employers Network. We work with employers of nannies, house cleaners, home attendants, and other domestic workers to ensure that their homes are equitable for employer and worker alike. We're part of the DC Long-Term Care Coalition. I'm here today because we know that care and caregiving is intertwined with not only labor rights, but labor opportunities, which people in the district deserve more and better access to so that they can both join and strengthen the workforce. As we approach hard attacks on our already vulnerable healthcare system, DC should be on the front lines of defending all workers in the care economy, including nurses, domestic workers, and other caregivers by fostering more streamlined opportunities for the workers taking care of our aging populations and other impacted communities like the disabled community that also benefits from long-term care. DC does not have to start from scratch on any of this. In fact, this has already been mentioned by others here today, but by beginning to implement the Certified Nurse Aid Amendment Act of 2024, the district could start to see surges of CNAs who could start filling the gaps in the home care crises, especially given that CNAs from Virginia and Maryland can now also work in DC with the temporary license established by the same bill. Hand in Hand is here to be a part of ongoing efforts to make the district a more worker-friendly city that also cares about the impact of labor on the economy. It would benefit everyone in the caregiving world to have a more trained workforce, and people who rely on home care know that appropriate training supports a safe and beneficial continuum of care, which is critical to people who live independently. We believe that a streamlined and transparent path workers can take to receive the required certifications would be most beneficial to the care economy in DC. Lastly, I'd like to emphasize that across the city, employers of caregivers already do want to make sure that the caregivers they employ are also taken care of. Hand in Hand is working across the district to ensure that employers of caregivers are aware of their responsibilities so that we can build bridges between employer and employee. On the side of DC, district government agencies can start with more transparency around how the implementation process of the Certified Nurse Aid Act of 2024 is going. Thank you.
Thank you for your testimony. We have 4 that will provide virtual testimony. You have that? Okay. All right, we'll get to that. But I just wanted to rather quickly just ask a couple of questions. Make sure I'm on where you are and what you're sharing with us. You're basically, Ms. Faison, you're basically providing us with statistics more than anything else, and we appreciate having that. But you've been here, I think, through much of the discussion today. And do you have any thoughts about how we might focus on creating an overall plan and process, like an omnibus approach to how do we get the health services and the workers that we need and what the ingredients might be? All right.
Thank you so much for your question. Yeah, I mean, I think as some other folks have mentioned today, like having a greater coordination between all of the agencies and committees that in DC that work on long-term care, I think would help with some of the siloed nature of all of this work. I also think that making sure that there are as many opportunities for direct care workers and recipients of care to have a direct voice in pay and compensation is super vital as well. So those are just a few things that I think can increase the level of coordination where a lot of these incredible conversations seem to be happening separately. So thank you so much for your question and your time.
Thank you very much. And Ms. Henrique, come on. We want to hear from you. What are your thoughts?
I'd love to see, ongoing, maybe public reports from the advisory committee that was created from the Certified Nurse Aid Amendment Act be published and just have that accessible to the public to see how that's going. And I think our work at the DC Long-Term Care Coalition already has a lot of stakeholders that are members and that are working on this. So more collaboration with people or groups like the DC Long-Term Care Coalition would be beneficial for everyone. Yeah.
Thank you both very much. And we'll turn to our virtual witnesses. We're going to hear from Rochelle Ellison, who is the Assistant Director of People for Fairness Coalition, followed by Jake McDonald, the Senior Policy Advocacy Specialist for PHI, and then Rajan Thomas, President of DC Home Health Association, and finally, hopefully, April Young, Senior Director of Strategic Initiatives for Advancing States. So we'll turn now. And we'll see who's on. Okay, I believe Mr. McDonald, you are in the room.
I'm here, yes.
All right, we'll hear from you. Thank you so much.
Thank you for having me. Jake McDonald, I'm the Senior Policy Advocacy Specialist at PHI. We're a national nonprofit organization and the nation's leading authority on what we call the direct care workforce, what you all have called the long-term care workforce today. We promote, this is really the theory behind PHI, we promote quality direct care jobs as the foundation for the quality care that people need. I want to try to complement the testimony of our partners in the DC Coalition on Long-Term Care by making two recommendations. First, that this council work toward a universal training and credentialing system. And two, and crucial to the success of the first suggestion, that this council support the district's agencies in coordinating their efforts towards that goal. So fundamentally addressing direct care job quality is key to cultivating the workforce the district needs. Implementing the Certified Nurse Aid Amendment Act of 2024, as you've heard today, is a strong starting point, particularly for our suggestion of building a universal direct care training and credentialing system that would include core competencies, training standards, and portable credentials. So the idea is that workers should be able to develop entry-level specialty and advanced core competencies and then carry their training and credentials across different settings and roles. That allows them to specialize, to get wage increases, to advance in their careers, and to have greater job flexibility and stability in the workforce. I want to highlight 5 key steps we suggest this council support district agencies to do to move towards this goal. One is to identify universal core competencies that will support the shared curriculum for the home health aide and certified nurse aide roles. 2 is to invest in the development and delivery of high quality training and certification programs, including specialized competencies and more advanced direct care roles. 3 is to increase the capacity of education and training providers to meet the needs of this workforce while removing barriers to and creating incentives for people to participate in them. 4 is to offer career navigation and other services that support retention and helping workers find career opportunities. And 5 is to ensure wages are competitive, both within and across roles, in care settings, and to make sure that you're both attracting and retaining workers. Moving to the second suggestion, to do this, to develop a universal training and credentialing system, this council, we think, should play a central role in coordinating relevant district agencies. So successful coordination must be grounded in a whole of government approach that aligns agencies around one mission. PHI has done quite a bit of work helping states that are prioritizing investment in a universal system to implement 3 different strategies for trying to accomplish this coordination. One strategy is to convene around a specific goal. So California, for example, aims to develop a set of core competencies across its direct care workforce, while Wisconsin plans to recruit 10,000 new direct care workers. Both of these goals, even though they're different, offer a clear objective that helps agencies join together, understanding that they're trying to achieve and how each of them can contribute to that. Second strategy is to ensure the right people are at the table. So New Jersey has brought together its departments of Human Services, Health, and Labor. Illinois is working across every division responsible for a Medicaid waiver program. So despite different goals and scopes for their interagency work, both states took 2 steps. They determined which entities should be involved in the conversation, and they ensured officials with the appropriate authority and expertise were attached to the project. The third suggestion is to work with external partners. So Michigan's agencies have partnered with advocates at the Impart Alliance. Colorado's have partnered with workers in the Direct Care Workforce Collaborative. These relationships with academic institutions, worker advisory groups, and advocacy coalitions drive change because they bring in expertise and perspectives and resources that state and the district agencies do not have. Here, in the case of DC, the DC Coalition on Long-Term Care can be an invaluable resource to this council and to its agencies. In conclusion, thank you for the opportunity to speak today, and we'd really love to continue working together on these crucial issues.
Thank you very much for your testimony. Anyone else? Okay. Mr. Thomas, I believe you're on.
Good afternoon.
All right.
Person Bonds and the committee that's with you today. We welcome this opportunity to present my testimony. Along with others who have testified, I'm also part of the DC Coalition of Long-Term Care and happy to be here. I'm the president also of the DC Home Health Association and the CFO of HMI Home Health Agency, which has been consistently providing services in DC for 35 years going on. So we're proud to be part of this service delivery system here. You had heard different things about all the different initiatives that have begun, and we are certainly grateful for the council for moving and pressing forward with those. I'd like to present today a few observations and considerations, as this is supposed to be a strategy, beginning of a strategy to end this workforce shortage. So I'd like to present a few points that I would like to consider. As we all know, the job of home health aide is not an easy one. They face many challenges working in patients' homes. They work alone, not by choice, but because that's what the reimbursement model is as such. They work with patients under various medical conditions, including dementia, fragile with various degrees of mobility, or in some cases, even weight issues. Therefore, they must be paid sufficiently to be attracted to this particular workforce. And thanks to DHCF and ARPA, the initiative to increase their wages above the living wage, 110% above in 24 or in 24 and in 17.6% from 24 onward and continuing now into this year has been very helpful. We have seen many return to the workforce. However, we have also had to do more. We have had to provide additional bonuses so that folks can be rewarded for being consistent with their work and to encourage others to continue join. And it would be great if funds could be provided to agencies to do such extra measures. Another thing that has been highlighted, of course, also has been the lack of training schools. Only 2 certified training schools now for home health aides in DC, whereas there was 7 at one time. In fact, UDC, who used to do that, is no longer in that field. So I think definitely that is something that we need to consider along with other programs. We also know that there are many people who speak Spanish who are not able to be covered by aides because we do not have enough Spanish-speaking aides. So I think that's something else we would need to reach out to various organizations such as churches and community organizations to be able to encourage people to get into the workforce. In conclusion, I would say that we're indeed grateful for this council to bring us all together to present our ideas. And I would say just one more thing, licensing. We talked about efficiencies in licensing, multiple licenses. A home health aid license is there, then the DHCF requires a Medicaid provider enrollment. These are all various challenges faced by the caregivers, and we would certainly look towards, as was mentioned by Jake McDonald earlier, efficiencies and in terms of not only work, but in terms of systems would be a great boon in reducing this shortage. Thank you for your time.
Thank you very much for your testimony. And I believe April is on.
Yes.
All right, Ms. Young, we're ready for your testimony.
Fantastic. Council members of the Committee on Health and Committee on Executive Administration and Labor, my name is April Young, and I am the Senior Director of Strategic Initiatives at Advancing States, a nonprofit membership association that works to improve and sustain state systems delivering long-term services and supports for older adults, people with disabilities, and their caregivers. As you know, the already high demand for direct care workers in home and community-based services, or HCBS programs, is projected to grow exponentially in the coming years. States are spending more and more time working to identify meaningful and effective strategies that recruit, retain, and support direct care workers in order to continue to administer cost-effective HCBS programs that enable people to remain independently in their homes. The strategies I will discuss today include obtaining crucial input from direct care workers, data collection processes, and matching registries. Through our work with state members, Advancing States has seen firsthand how the worker voice can inform state staff about the strategies that mean the most to workers and help to amplify the need for direct care workers on a state and national level. Whether it's a marketing campaign, creation of a statewide direct care worker plan, or a peer mentor initiative, obtaining worker input and feedback from those in the field is always a good idea. As council members in government, I don't have to tell you about silos. States across the country regularly struggle with breaking down communication barriers between agencies. This issue is seemingly amplified when states review their data collection practices for the direct care workforce. To promote informed decision-making, Advancing States strongly encourages states to identify what direct care workforce data is already being collected and from where that information is derived.
Strategies to address direct care workforce data include forming multi-agency work groups composed of health and human services agencies, Medicaid agencies, and workforce agencies, among others. And another strategy is to participate in a survey, such as the State of the Workforce Survey, which collects data from providers and then provides states with a wealth of information about the workforce, from average wage to benefits offered to provider strategies for retaining workers. Somewhat related to data collection, Advancing States also supports the use of matching registries, such as Direct Care Careers, that allow workers to create profiles and connect with provider agencies looking for workers or individuals utilizing a self-directed service delivery option, sort of like the Services My Way option that was mentioned earlier. Registries provide a streamlined process for individuals and agencies to hire workers. They empower workers to find work according to their availability and skill, and they provide a centralized source of information for states. Council members, thank you for your time, and I would be happy to provide additional information on any of the aforementioned strategies. Thank you.
Thank you for your testimony. I would just like to add, thank you, Ms. Young, in talking a little bit about the matching registries. I think that's a unique idea. Usually, it is each business plan likes to keep their workers to themselves, but I think the idea of a matching registry would have some merit in looking at how we can improve the system that we already begun. Thank you very much for that. And thank you, Mr. McDonald and Mr. Thomas, for your testimony. I think we're moving close to, yes. Thank you all very much for your testimony today.
Thank you.
Our next panel of witnesses includes our government witnesses, of course. And Sam Hurley is Senior Deputy Director of Healthcare Systems and Preparedness Administration located at the Department of Health. And he'll be joined by Joan Williams, the Clinical Services Officer for the Department on Aging and Community Living that we fondly refer to as DACL. And Sam, you can begin when you're ready.
Thank you so much. Good afternoon, Chairperson Henderson, Chairperson Bonds, council members, and staff of the Committee on Health and the Committee on Executive Administration and Labor. My name is Sam Hurley, and I am the Senior Deputy Director of the Health Systems and Preparedness Administration at DC Health. On behalf of our Director, Dr. Ayanna Bennett, I am pleased to testify today on the current state of the long-term care workforce and the efforts DC Health has and continues to undertake to strengthen it. Long-term care services are critical to maintaining an effective and high-quality healthcare system. The professionals who work in long-term care settings support some of the district's most vulnerable residents, predominantly older adults and persons with disabilities. Long-term care entities require a robust workforce that spans a range of expertise from unlicensed professionals, such as administrative, food service, and janitorial staff, to licensed healthcare professionals like nursing assistive personnel, including certified nurse aides or CNAs, rehabilitative specialists, social workers, and long-term care administrators. As of March 2025, the district has 13,109 nursing assistive personnel, 5,282 social workers, 1,322 physical therapists, 885 speech language pathologists, 917 occupational therapists, and 60 nursing home administrators. Over the past several years, DC Health has observed health professional workforce capacity concerns, including a marked decrease in the number of CNAs. We recognize that these changes in the district's healthcare workforce capacity pose a serious challenge for long-term care entities to maintain the quality of care that they are expected to deliver to the people that they serve. Nationally, 94% of long-term care patients and residents are over the age of 65. Also nationally, the share of adults aged 65 and older at the national level grew by 34% from 2012 to 2022. As the country's population continues to age, we will see an increased demand for long-term care services. According to the U.S. Bureau of Labor Statistics, employment demand for people serving seniors and for those with disabilities is expected to grow by 26.5% between 2023 and 2033. However, national workforce data indicates that the number of people working in nursing and residential care facilities is still lower than pre-COVID-19 pandemic levels. DC Health is committed to addressing the workforce challenges in partnership with district government agencies, patient advocates, long-term care entities, and our federal partners. DC Health reorganized this year to advance our vision of supporting and sustaining a comprehensive healthcare system for the residents and visitors in the District of Columbia. This led to the establishment of HISPA, which safeguards the health and well-being of district residents, visitors, and businesses by regulating health professionals and facilities and coordinates emergency preparedness and response efforts. DC Health's primary engagement with long-term care providers is as their regulator. We regulate the district's 88 long-term care facilities, which include nursing homes, assisted living facilities, home care agencies, and home support agencies. DC Health enforces safety and quality-focused requirements such as nurse staffing ratios, patient rights protections, and individual service plan requirements. We also serve as the state agent to inspect and enforce Centers for Medicare and Medicaid Services, or CMS, requirements. Our Office of Health Facilities also provides technical assistance when possible to long-term care facilities. DC Health also regulates long-term care health professionals and has recently made improvements to the regulatory framework for healthcare professionals, including the implementation of the Health Occupation Revision General Amendment Act of 2023. This legislation includes multiple provisions aimed at making healthcare career pathways more accessible to young persons. It also ensures that the long-term care concerns that are elevated directly with the Board of Nursing by establishing dedicated subject matter representation. Additionally, we are also working to implement the Certified Nurse Aid Amendment Act 2024. This legislation creates a single nurse aid credential, the CNA, which will allow professionals to work in both clinical and home settings. Existing HHAs will be grandfathered into this license. To advise on this transitionary process, the legislation established a 5-person advisory committee on certified nurse aides and nursing assistive personnel. DC Health has appointed the committee members, and their first meeting actually took place this week, as you heard earlier. They will develop recommendations for implementing this transition, including a new CNA training curriculum, updated certification requirements, educational provider requirements, and the transitionary process for those who hold existing licenses. Notably, this transition will impact professionals currently certified as both CNAs and HHAs to ensure that they possess the appropriate competencies to hold this new blended CNA credential. Once completed, DC Health will issue regulations to formalize those updated requirements and standards. We would like to acknowledge the Long-Term Care Coalition, the DC Healthcare Coalition, training providers, and a multitude of other partners who have been active throughout this transitionary process. Outside of our regulatory reforms, we increased training capacity and supported pathways to employment. While we have seen decreases in nursing assisted personnel training capacity, we are working to reverse this trend and expand capacity by supporting the current 13 CNA and HHA training programs. We've also heard concerns from training providers and students about the lack of seats for testing and have developed multiple solutions. Board of Nursing staff are now providing weekly open test seat reports to educational providers to ensure increased transparency around psychomotor or skills testing availability from the National Exam Administrator, Credentia. This information will empower educational partners to match students with open testing slots. We are also working with the Office of the State Superintendent of Education and the University of the District of Columbia to add new testing site capacity across the district. We have made significant progress in implementing the High Needs Healthcare Career Scholarship Program. This scholarship program addresses the healthcare workforce shortages, including those in the long-term care settings, by providing funding for district residents to attend healthcare training programs. We issued a competitive grant process to support the educational partners and have selected 5 training providers, 3 of which are dedicated CNA training programs. We have received an additional approximately $3 million in additional scholarship funding from the Department of Healthcare Finance to expand this program. Training providers are actively recruiting aspiring professionals for these educational opportunities, and the funding will begin flowing April 1st. By the end of fiscal year 2025, we anticipate training an additional 126 CNAs in addition to other high-needs healthcare career professionals. This scholarship supports students with not only tuition costs, but other financial assistance, including covering the cost of national exams, but all equipment and criminal background checks. While these efforts are primarily aimed at recruitment, we are developing robust career ladders that contribute to greater retention within the long-term care space. Creating a system without career mobility and growth opportunities isn't appealing, and ultimately results in a workforce system where more people are leaving than those who are entering. While there are significant challenges facing the long-term healthcare system, DC Health continues to be a proactive part of the solution. We will continue to build and expand relationships with the healthcare system and strive towards implementing effective and data-driven initiatives that further improve our healthcare system. I would like to thank the council for hosting this important roundtable to shed light on strategies to address these workforce challenges. We look forward to continued engagement with the council on this very important issue, and I am available for any questions you may have. Thank you.
Thank you. Ms. Williams?
Yes, thank you. Good afternoon, Chairperson Henderson, Chairperson Bonds, members of the Committee on Executive Administration and Labor, members of the Committee on Health, and committee staff. My name is Joan Williams, and I serve as the Clinical Services Officer for the DC Department of Aging and Community Living, known as DACL. It is an honor to testify on behalf of Director Teron P.W. Hines today at this roundtable. At DACL, I oversee the Clinical Services Cluster, which includes Medicaid enrollment services, assisting seniors and adults with disabilities in navigating Medicaid eligibility enrollment, the Community Transitions Team that supports individuals transitioning from institutional settings back into the community, and the Case Management Team, who provides comprehensive community case management to ensure seniors receive services they need to remain independent. In addition to these teams, the Adult Protective Services Unit, APS, investigates and addresses reports of abuse, neglect, and exploitation of vulnerable adults. These teams work closely together to support and protect the district's seniors, ensuring that they have access to the services and resources they need to live boldly. DACL's mission is to advocate, plan, implement, and monitor programs in health, education, and social services for older adults and residents with disabilities, as well as their caregivers. Our work promotes longevity, independence, dignity, and choice for all of our older district residents and those with disabilities. We ensure the rights of older adults and their families while preventing abuse, neglect, and exploitation. Our work is guided by the core values of service, excellence, respect, compassion, integrity, and accountability. And we strive to strengthen service delivery by engaging community stakeholders and partners to effectively leverage resources. One of the critical programs DACL funds is the Homemaker Program, which provides free in-home aid services to seniors who do not qualify for Medicaid's Elderly and Persons with Disabilities waiver, EPD waiver, but also who cannot afford private pay services. This program is administered by Home Care Partners, who you've heard from today, and has been a lifeline for vulnerable seniors in the district for over 40 years. Through the Homemaker Program, trained and certified home health aides assist seniors with personal care such as bathing, dressing, grooming, the light housekeeping and laundry, meal prep, grocery shopping, and it provides supervision for our frail seniors, including those with Alzheimer's disease and related dementias. Each participant serves nursing or social work case management in addition to their home health aid services. The Homemaker Homemaker program currently serves approximately 161 active clients with 133 aides and staff, approximately 80 of who are licensed to work here in the district. To qualify for the Homemaker program, an individual must be a DC resident, 60 years or older, have a documented medical need for in-home support, and not qualify for EPD waiver, but be unable to afford private pay. This program has proven very successful at gap filling, though it is limited in how many clients it can support, even though we see a rising demand. DACO's grant monitor, Stephanie Bryant, works closely with home care partners to ensure compliance with program objectives, conduct site visits, and monitor service delivery. And we track referrals made through C-STARS, DACO's case management database system. What we consistently see, whether through the Homemaker program or EPD waiver services, is that many clients do not receive enough hours of care to meet their need. Additionally, workforce shortages place stress on both the seniors and their family members. Staffing shortages lead to longer wait times for waiver-approved individuals to obtain the recommended number of home health hours, as well as delays in transitioning individuals back into the community to age in place. Through our participation in the Age-Friendly DC Task Force and Long-Term Care Coalition, DACO actively collaborates on strategies to address the caregiver workforce shortage. We recognize the urgency of this issue, which is why we supported the Certified Nurse Aid Amendment Act of 2024, and which expands the scope of work for certified nurse aides, allowing more professionals to provide care in both clinical and home settings. DACO remains committed to ensuring that all seniors in the district have access to high-quality, comprehensive care. While the Homemaker program plays a vital role in bridging service gaps, we must continue to work collaboratively to address workforce challenges and enhance long-term care support. Thank you for this opportunity to testify today.
Thank you so much to both of you. Councilmember Bonds, do you want to do 10-minute rounds for the government witnesses? Okay. Do you want to go ahead and go first? You go first? Okay, great. All right. Thank you. All right, I have some DC Health questions. I have some DACO questions, but first, I want to follow up, Ms. Williams, on your testimony about the DACO Homemaker program, which I do feel like is providing a gap filler, if you will. You mentioned you have 161 active clients right now. Is there a wait list?
So I actually, we oversee the Homemaker program as our grantee. And if I could, Ms. Marla Lahat is in the room who oversees it directly and could speak a little bit to the wait list directly. Would you?
Yep, Ms. Lahat, if you want to come sit in between them.
Not to put you on the spot.
Thank you. Yes, we do have a wait list for the program. We've made great strides this year in reducing that wait list. It is a combination of two factors. One are workforce shortages, the other is funding. The program is funded very generously by DACO, but it's not enough. And
how big is your wait list?
Right now, the wait list, it's under 100, which is the best it's been in a very long time. The clients who are currently waiting all came on in October of 2024 or after.
Okay.
So that's not very long for us.
So in terms of the program, again, it's sort of a gap filler, if you will. Do you have a time limit in terms of how long someone can continue to receive services?
Excuse me. No, we do not have a time limit. That is one of the benefits of this program, that people can remain on it for as long as they need it. And it really does make a difference, because providing that little bit of help when someone is at the beginning of their care journey, if you will, prevents them from getting to the point where they need EPD waiver services or where they need to go to a facility. So it's really very effective. The flip side of that is people stay on the program. We have people on the program who've had an aide for 10, 15 years. And every person that stays on the program doesn't open up a slot for somebody else.
Right. Ms. Williams, how much is this grant?
I would have to get back to you on the exact number.
Okay.
I can give you an approximate. Is that?
Oh, she's like, I know the books.
Go ahead. It's my ground. Yeah, it's, right now it's about 2.4 million.
2.4 million.
Important to note too, we work collaboratively with the Home Care Partners team for emergency APS cases. So
Adult Protective Services
yes,
cases.
yes. So if we have an incident with an individual who has an open APS case, we can reach out to Marla for an emergency aid placement.
Separate and apart from the homemaker program.
Yes, and those funds are currently provided federally. And, I'm not sure of the future of that, but we would continue the relationship for APS space. So that could impact Home Care Partners' ability to take on additional homemaker clients.
Okay, so is the 2.4 million encompassing both programs?
It does right now. There's a lot of overlap because as the APS referrals, as the protective service issue is resolved, which hopefully it is in a relatively short amount of time, those individuals stay on the program because they continue to need aid service. So their protective service issue is resolved, but their need for an aid has not changed. And because we have both parts of the program, we just transfer the funding. It's seamless for the individual. They don't know where the funding is coming from specifically.
But Ms. Williams, for the APS referral or the emergency APS cases, you said that's federally funded?
Yes.
Is that which agency, HHS or?
ACL. HHS, Administrative of Community Living, we work directly with them for elder justice funds.
Okay.
So that's where that has come from previously.
And I'm sorry, if I could add to the homemaker budget is both federal and local. It is primarily local funds, but there are Older Americans Act funds that fund that program as well.
Yeah, we got to sort of break down some of these questions of like what's federal versus what's local, because, our federal part, some in the federal, they're just cutting without asking these questions of like, what is this?
Right.
And even as you sort of bring up like, elderly justice, I think on their list of words to search is justice, and like not knowing, hey, this is actually a vital thing that can help and change, I think is certainly important. Ms. Williams, when you guys are, have someone who's on the homemaker program, are you constantly monitoring whether or not the person is still eligible? And by that, I mean, right, at some point, their finances might have changed where and they do now qualify for EPD waiver. How often does someone have to, I guess, renew eligibility for the program?
So the monitoring that goes on for every individual client is conducted by Home Care Partners directly. We can, they have a social work staff person who can work with individuals to apply for those benefits if necessary. But of course, if they determine that somebody is ready to come off or who might now be eligible for an EPD waiver, they can refer back to DACO to walk our Medicaid Enrollment Services team to get waiver and go through that process.
Yeah, a friend of mine recently did this presentation where it wasn't for, it's for us, not older adults, but those who might have parents who might be aging, to understand the complexities of Part A, Part C, Part D, what's covered, what's not, what's the finances, this, that, third, blind trust, how much money you can have or not have in order to qualify, all of these different things, which I think can be very complicated, if you will, for families just in general to understand like what the options are. How do we, how does DACL sort of approach that from the children and loved one perspective of, let me give you the pre-information before you need it. And then two, how would someone find out about even the opportunity for the homemaker program?
Yeah, so we are available to support family members, caregivers with finding information that might serve the senior, as well as supporting the senior. So if individuals contact our information and referral line, they might know specifically what their questions are, and our DACL staff person can provide them with the appropriate referrals. Generally, if there's a lot of questions about what do I need, we're planning, we may need a home health aide in the future, they'll come to the case management team. So our community case managers go out into the homes of individuals. They can offer over the phone with, of course, the permission of the senior, but over the phone consultation to maybe sons or daughters who live out of the area, or set up meetings to meet with individuals and families as a whole to walk through what are eligibility requirements, such as financial requirements for EPD waiver, what spend down might look like for that family, available resources such as the caregiver program and home care partners. So we work with them in the case management setting.
Okay. I feel like it's like a whole new world, right? Even just the idea of like dental is not covered. And I'm like, wait, what?
Yeah. And it's a lot. And we also have our SHIP team, which is our state health insurance program. And they do a lot of community outreach and are actually revving up to reach out more to walk through Medicare specifics, like the A, B, like the whole alphabet and what it covers. And they can work with communities, families, individuals, all of that good stuff.
Okay. I'm over my time. Well, not over my time. I don't have enough time to ask another question, really. So Councilmember Bonds.
Thanks very much, and thank you all for your presentation. Of course, Ms. Williams knows that when we have our DACL budget, we'll be talking numbers, and so I won't go into that today. Today, I'm more concerned with you helping the public that may be listening understand how do they access the home care system and the benefits that they can derive from it to help them stay in their home or what have you.
Sure. So at DACL, we serve the whole city. And so that there's many diverse populations within our city. So we can offer resources and information sort of across the spectrum. So if you come to us again in our case management program and you're seeking understanding about maybe a private pay home health aid situation, how do you figure that out? We can offer those resources and guidance for how to get those resources set up in your home. We also can walk individuals through the Medicaid enrollment process and the waiver process. So that starts anywhere from somebody reaches out to DACL and they haven't even seen a doctor in years and they need to start with linkage to a physician so they can get documentation completed to start that process, or somebody who has a family member who's helped them gather everything they need and they just need us to process it. We're a bridge that offers all of the information to explain that. We walk you through the process to get waiver and services, and then we work with our partners at Department of Healthcare Finance to connect you with their providers for case management and the home health agencies. So we sort of can meet people wherever they are in that process and address, different teams. We also have our EAC team, which is our communications and outreach, and they offer presentations about all the different services that DACL has. And so if organizations are just looking to see where we even fit in like the larger scope, we can meet them there.
Thank you for that. And so then I have to ask Sam, could you talk to us a little bit about what happens once the application gets to your shop? Because it seems to take 6 months to get through. So help us understand the time lag.
Thank you, Councilwoman Bonds. Can you specify which application? Are you speaking about individual licensees or facilities?
Okay, no, it's the service. I'm sorry. Yes, you're right.
So when speaking about service licensure or facility licensure, that process requires inspections and for them to go through the full gamut of the application that is submitted. I personally cannot speak at this moment to the exact time frame for that, but I can get back to you with the average length of time it takes for entities to become licensed as home health care agencies. I can certainly get back to you with that information.
All right, well, I would appreciate that. I also wanted to, I have a few prepared questions that I wanted to check with you on. Can you tell us about the types of accommodations that are available to seniors and individuals with disabilities? If they're looking for a place to be, a family member frequently calls our office and they're like, I need a place for my mother, my aunt. Where do they go to get that? I mean, I know we can go to DACL. We do DACL, but where do we go?
Yeah, thank you, Councilwoman. I do appreciate that question, and I think that speaks to one of the things that DACL is very good at, which is care coordination. That is one space that DC Health doesn't have a huge footprint in, is direct care coordination among individuals. So we are looking at the system as a whole and making sure that the system is able to wrap around you. But currently the model is not about how to help you navigate that system. That isn't something that DC Health does explicitly. But what we do try and do is connect people when we do hear about these situations, connect them to resources like DACL, their MCOs, other entities that help with care coordination, because they can help get them into these entities. In addition to that, we do make available public listings of the licensed facilities that we do regulate, so that people can access that information and make contact with those potential entities to, potentially become a resident, et cetera. But as far as individual care coordination, DC Health has not stepped into that particular vein. Instead, we depend on healthcare professionals, primary care physicians, specialty care physicians, and other supporting organizations like DACL, Healthcare Finance, and others to help with that care coordination model of how to move people throughout the system that does exist.
So in your opinion, are you telling us that there may be a need for an ombudsman function that does these kinds of things, that can help a family navigate the system and understand the types of services that they need and where they may go? Are you telling us that is something that you understand is necessary, but we don't really have a process in the government? We can give you a list of 8 places, for instance, but we can't help you decide or narrow it to 3 locations that can provide the services that your family may need.
So what I would say is, I think we need to make sure we have a good inventory of the capacity of our systems that currently exist before we create a new role. Where is the gap between the services that DACL provides, the services that Healthcare Finance provides, the information that we make publicly available, the services that MCOs provide, et cetera? Where is the gap between those potential services to make sure that we are addressing the actual gap in the system versus duplicating something that is being underutilized? And if we identify that there are resources like the care coordination resources and the resources that are available at Healthcare Finance, if we realize that they're being underutilized, I think it presents an incredible opportunity for us to work collaboratively as a government to help promote those existing resources to make them used more efficiently and effectively. But I think the first step is identifying where is the true gap here, and are we underutilizing existing resources that we may be able to leverage?
All right, well, thank you very much for your response. Thank you, Chair.
I wanted
to add something.
Oh, yes, sorry.
My apologies.
Oh, I know who you are, but if you can introduce yourself for the record.
Aisha Nixon, Associate Director for the Office of Health Professional Licensing Boards. So just to the point, there is existing collaboration, and just as Mr. Hurley stated, we do referrals to the Ombudsman's office. So the coordination actually exists with healthcare finance. They have a case management team, and so for the home health coordination, it's with healthcare coordination, the ombudsman resides in healthcare finance, and then with the long-term care group, it resides with DACL. And so we do collaborate with that team and that office regularly.
Thank you for that additional information. I guess I'm sitting here and understanding very clearly what Dr. Salvedio was his point. And that is, we need a plan because the city is aging. And, we were just cited as the best place in the country to retire. So that means everyone with money, without money, are going to be moving here. And so how are we really going to accept this population and work with those that we have here? So just trying to understand thank you so much.
Thank you. On that, or in that same vein, the DC Healthcare Workforce Partnership in 2024, they do an annual health occupations report. And they put out a scorecard on progress that we have made or not. One opportunity identified in this latest report in 2024 was to spearhead the development of braided funds across agencies and programs with workforce development resources to address some of these upcoming or currently here workforce challenges that we currently have. Has DC Health or DACL ever discussed the feasibility of doing this around direct care workers, braiding funding from a variety of different sources to be able to, whether it's boost salaries, provide training and support, et cetera?
So I can speak from DC Health's perspective. We have been working with healthcare finance to attempt to braid funds to support increasing the healthcare workforce, with the example of the $3.7 million funding that supports high needs healthcare career scholarship. That is one way that we have integrated that into the funding that was allocated by council to make sure that we are bolstering our capacity and our impact across the district. Based on DC Health's current model of, we have very few direct care services that we render outside of the clinic that is offered by DC Health. We do very few direct care services. So I think that is a little bit, it's challenging for us to weave some funding together because it's not actual services that we're providing directly.
True, but I think the interest of DC Health is around how do you bolster the healthcare workforce, which you all license, right? And ensure that you have the pipeline to meet the need of the agency on the other side, who I think is probably more direct client facing in terms of the work.
Yeah, absolutely.
Okay. Well, I'll ask that same question. Has DACL talked to the other agencies about how to better braid some of the funding that you all don't necessarily have available, but healthcare finance or DC Health might?
So we work with Department of Healthcare Finance regularly. We meet with them bi-weekly to talk about concerns with different providers and the best way that we can serve our population. I have not specifically spoken about braiding those funding streams because we rely on them to work with their providers to do the paying out, as you have said. But we're open to collaboration and providing insight from what we hear from our clientele for sure.
Okay. And where does age-friendly DC fit in all of this?
So Age-Friendly Task Force, we have member of our staff who currently serves on that task force to work with them on different initiatives. I don't have the specifics as to where her role is currently, but we can provide an update on that,
Okay.
certainly.
Sam? Have you guys been talking to Age Friendly in your work?
I can get back to you on the intricacies of how those conversations have been going. Yes.
Okay. I'll be transparent in terms of, and health, the deputy mayor for Health and Human Services kind of knows this. I feel like Age Friendly, we convene, we spend the money to put out this like nice, flashy, glossy report. And then it's a report that is not action driven, because I do feel like in terms of convening around this issue around workforce, I shouldn't be going to each individual agency. I should be able to come to Age Friendly DC and say, who have you brought to the table? What is the plan? How are we moving the money? X, Y, or Z, because that's all in the deputy mayor's shop. Now, I recognize that they have a leadership transition that's happening with Age Friendly, but I'm having to ask this question because I feel like, you know, the data shows what the data shows about, what did I say? We're projecting that our population of older adults could increase by over 50% by 2030. We are not ready at all. We don't have enough facilities. I don't got enough staff. I don't got enough nurses. And so I think that was sort of like the impetus here in terms of like, what's the plan and how do we move fast on some of that? During the performance oversight hearing, we discussed barriers to testing, including your testing partner, Credentia, not offering standardized testing dates or canceling tests at the last minute. And, you know, thank you, Deputy Director, for being very responsive to these concerns. I just have a couple of additional questions. How many testing dates have been offered in the last 6 months?
I can get you that number specifically in just a moment.
Okay.
But I have it on my laptop.
Oh, okay.
Yes, we have it here. We can get it for you.
Yeah. In that same vein, I'm curious, how many have they canceled?
I have that number too, and I will get that for you in just a moment.
Okay. So OSSI shared that they're working with DC Health to establish the Ward 5 Advanced Technical Center and the Ward 8 Center as testing centers for the CNA and HHA credentials this summer. I've toured the Ward 5 site and it's nice. I mean, we spent some money building out that space, so like let's use it as best we can for these things. Do you all have a target opening date for these sites to be able to start testing?
The Ward 5 site will be sooner than the Ward 8 because they're still building that space out. But the current project period is that it will be operational by the end of September.
End of September. Okay.
Yes, ma'am.
Is what else is needed for an ATC to serve as a testing center? Like, what are there specific? I mean, obviously the Ward 8 they're building, so there's that. But is there specific criteria necessary in terms of the space in order to serve as a testing site?
There's less requirements on the physical space aside from having a room and a holding area for students to sit and wait before they test, and more emphasis on the equipment and supplies that are needed to conduct the tests there. So you have to have a hospital bed, you have to have a mannequin, and we're not talking about the, scarecrow mannequin that you pay.
No, the responsive one.
Yeah, exactly.
Yeah.
Which typically are not inexpensive mannequins. And so it is the equipment that's required to procure that. So currently we are finalizing MOU modifications to transfer over $300,000 to OSSI to pay for this equipment so that they are ready to host those exams.
Okay.
That's what we're working on right this moment.
OSSI has one of those mannequins. Freaks you out because you're standing there and then all of a sudden something like you're like, whoa, hey. You should go check that out, Councilmember Bonds. It's very lifelike, is all I'm saying. Okay, so we discussed that Credentia is a contractor that was chosen also at the national level. Have they hired a full-time testing coordinator yet? You're already on.
Thank you. So currently, they have not hired a full-time testing coordinator for the District of Columbia. They do continue active recruitment of part-time individuals as well.
Okay.
But they have not hired a full-time person to our knowledge.
Okay, and has the Board of Nursing started to send the reports of spots available?
Absolutely.
I love this. We have conversations. You guys move to make changes. We check in a couple of weeks, and we've made progress. All right. So pass rates. Well, you know what? I'm going to ask Dackle a question so that Sam can find the information that we're working on. We heard testimony from the CEO of Forest Hills about their apprenticeship program that they have for CNAs. And I'm curious, how does DACL support CNA apprenticeship programs? Or in some ways, are you able to serve as trying to link facilities that you know about or contractors that you know about with our training centers who are looking to get their students experience in the field?
So currently, we, again, with our partnership with the Department of Healthcare Finance, they sort of would have more oversight into those facilities. Where we can partner is we are aware of different facilities, what openings they may have for residents, and sort of we know how to refer individuals to receive care there, but we're not sort of oversight of the CNA staff or the apprenticeship program for those facilities.
Okay, I'm over my time. Councilmember Bonds?
Thank you. I do have just a few questions. I wanted to know how does Medicaid and Medicare policies affect the financial stability of long-term care facilities and providers? Can we talk about that for a minute? We'll start with Dackle.
Okay.
Joan's good at that.
That's a big question. So we currently serve a large number of our residents in helping them obtain Medicaid supported services. So what I mean when I say that is we walk through the process for Medicaid enrollment on the state plan level.
So how many are we talking about when you say we serve a large number?
I will get you that exact number.
Okay.
And a follow-up. It's large. We walk through, we can help people get regular state plan. We can help individuals get approved for the waiver. And those services support their ability to stay in their homes, get medical care, and age in place and live boldly. So it's a high number, and I'll follow up on the specific.
All right. Sam, do you have a response for us? Thank you.
Yes, ma'am. So when we're talking about Medicaid or CMS policy, primarily federal CMS policy, it impacts the entities that want to go into business in this space because of reimbursement models, their profit margins, and how they are able to be a sustainable business operating within this space. And that further translates down to the same things that we heard earlier about the individuals and their wages. So if your profit margins are low and then you're unable to pay your staff competitive wages, it further detracts from the palatability of becoming an entity within this space. That also translates for the individual. If I'm going into this space making, $30,000, $40,000 a year, and that's limited based on the income that the organization makes as a whole, it's a self-limiting model because there's just only so many people who are interested in going in at that pay band. And so I think those are conversations that have to be held at the federal level of whether or not we can, if we can't reimburse higher than what we do now, some of those things are not policies that we determine locally, they're determined federally. And so it's a tough game to play insofar as we're having to navigate the waters both locally and federally with a defined pot of money. You know, we only have so much money to make that work.
Thank you very much for that response, because I want to make sure it is on the record for those who are listening and for our colleagues here at the council to understand that the need is great, it's expanding, but the allocation of resources is very limited. And, you know, we've got a dilemma on our hands. I mean, that's what you're really sharing with us. Can you tell us more about the Money Follows the Person Rebalancing Demonstration Project? And it'll talk, I guess, a little bit, you'll talk about individuals who have transitioned from nursing facilities to community through the project. I know DACL knows a little bit about it, yes. Well, you can, if you want to respond, if.
So I can just, from our perspective at DACL, we work with Money Follows the Person to assist individuals who are transitioning out of long-term care facilities back into the community. And so we do that with funds that support moving individuals out, home setup, making homes accommodate individuals, and then also through Money Follows the Person voucher program, which can place individuals in the community to live. So we work with that program quite often to get individuals out of the facilities. So that's sort of our role in it.
And for DC Health, my primary knowledge of the Money Follows the Person programming is the $3.7 million that was supporting the high needs healthcare career scholarship. So that was additional funding to support the training and education of CNAs, HHAs, and other PCAs. And that came from that same program, that same grant program.
All right, I appreciate that. And I think this is a perfect example of how we have our little silos. And, you know, I was thinking, Joan, when you were talking on behalf of DACL about, okay, how we prepare the person and the facilities and the systems to receive someone who is coming back in community. Thinking about that and all of those pieces, I wonder, does it automatically say I'm going to have a home care aide for a couple of weeks? Is that an automatic? It's like I think as a senior, I think that we need to have a picture, a process that is reliable so that if this happens in your life, then you know what to anticipate as you go through the steps of recovery, because that's what we're talking about. And we really don't have that in place at this moment. You know, the whole package. Slowly but surely, we can piece it together if a family member is determined, but otherwise, you're released from the hospital and there you are, and you got to figure out what to do.
Sure. And I think that one of the goals, at least of my teams at DACL, we're so direct service oriented and we're often working with seniors and their family members, is sort of also speaking to Council Member Henderson's point, is preparing individuals as best we can prior to something happening. So making sure that we provide options counseling in the event that there is an incident. So walking them through sort of, if you should have a fall and end up in the hospital and go to a rehab, what are your financial options of transitioning out? What are your housing options? What can your support system look like? So the earlier the better, but you know, as much information as people can have ahead of time for those processes is definitely beneficial.
And yes, I agree with that, but I also know that people respond to their situation. And, we can provide, I know that DACL does a good job of information dissemination. But when something happens, we ought to have a protocol in place that you can tap into. We have so many different programs, but how do we network them together to have some real solutions for people? Thank you.
Thank you. Okay, Deputy Director Hurley, I wanted to go back to you. I don't know if you were able to find the info.
Oh, absolutely.
Okay, great.
So from October 2024 until through March to date, there were 34 exams that were scheduled. 8 of those exams ended up being canceled. 4 of those were canceled due to what we think of as credential problems, evaluators.
Oh,
So
okay.
if they couldn't, if the evaluator canceled or something happened, that is a quote unquote credential problem. However, there were 2 of those that they didn't meet the minimum threshold. And so they have to have at least 5 students at the exam for them to host the exam. And so that is really one of the big impetuses behind us setting up this model of sending out these open seat reports is we don't want exams to be canceled because there weren't enough people signed up for the exam.
Yeah.
I do think it's important that of the 26 exams that did occur, there were 310 open seats for people to test. However, only 203 students tested.
So there were still about 100 seats that
107 seats
that could have been somebody.
that there wasn't anyone signed up for it. So that is another impetus behind us pushing this open seat report because the training centers couldn't see the back end.
Right.
And so that's why pushing this now so that they can see there's 107 seats that went unfilled in the past 6 months. Why? And so that's where we've really gone after, how do I get people in those seats?
Yeah, I mean, I still think, again, I go back to sort of like, the College Board, for instance, where they put out at the beginning of the year, here's the schedule of every time you could take the SAT. And then it allows for a student or their family or their counselor or whatever to like work back towards that date. And if we had that ability for the training centers, then they can say, all right, there's an exam that's going to be open on June 8th. Then we need to bring in a cohort of students in, I don't know, February in order for them to go through the program and be fully prepared to take the June 8th exam or something to that effect. Now, obviously, you're dealing with a private provider, and so those things, I appreciate that you guys are doing what you can, but I feel like that's something that we need to talk about. Now, availability of the exam is one thing. Passing the test, something completely different. So the most recent CNA and HHA test pass rate data that's on the DC Health website is from 2022. Y'all got to help us, help you. Got to update the data. Now, so I'm going to ask the questions based on the 2022 pass rate data, it indicates that the Board of Nursing requires a 75% pass rate for both CNAs and HHAs. Is that still the pass rate cutoff?
It is.
Okay. All right. That's good that hasn't necessarily changed. All right. So in the FY24 performance oversight data, 4 of the training schools had a pass rate over 80%. 4 had a pass rate in the 70% range, and 3 schools had a pass rate that was in the 50 to 60% range. When we are evaluating, or do we evaluate these training programs and have these conversations, right? I'm a little concerned that I've got 3 schools who aren't even close, like you're in the 50s, right? So you're not really even close to meeting that 75% number. But again, I don't want to send students to you if they're not going to pass.
So there is a process that the board goes through annually with all of our training providers to renew their approvals. And individuals who fall below that rate, they do get the opportunity to propose to the board a corrective action plan, and then the board determines if they're going to accept it. And then that's also makes their approval some type of level 1, 2, or 3. There's contingencies to that then they now have to either address, not that they have to address, and then they are reassessed the following year. We do our evaluations and assessments in collaboration with the Higher Education Learning Commission, HELP. And so sometimes that's why you may see some closures based on the fact that they are not meeting the requirements. But the board does provide opportunity, and the regulations does provide space where it gives the training programs the opportunity to self-correct.
Okay. What's our pass-fail percentage in DC?
I would have to get that to you.
Okay.
I requested it.
And again, I mean, I think that like if we're talking about expanding opportunities, there was a witness who testified earlier. Miss Kaby, Jacqueline Kaby from Home Partners, Kabe. And she talked about how, when she was sort of going through the process of switching over, she took the HHA coursework for free, which, okay, great. That's wonderful for her. But like, if we are out here offering free programs that aren't going to deliver you a license on the back end, then you have just wasted X number of weeks working towards something that we can't deliver on. And so I want to make sure that we have, folks that are making it through. So one recommendation from the Healthcare Workforce Task Force to increase the workforce pool was to reduce the time frame of returning citizens. Oh, okay. Got it. All right. To reduce the time frame of returning citizens being able to work in the field from 7 years to 5 years to align with Virginia and Maryland. Has DC Health considered this recommendation?
So it's part of, I would like to preface it. So this is based on the criminal background check assessment.
Yep.
So it is not based, the board does not say that you cannot apply for licensure, you won't be licensed. Again, with this license type or this group, they definitely work with individuals, the vulnerable population. So there are guidelines issued by CMS and related to individuals who may be on the registry for elderly abuse, and individuals who may have committed any type of Medicaid fraud or theft. They're usually, they more than likely may not get licensure. The criminal background check is a part of the assessment. It is not what makes a determination on if this person gets the license, but certain things such as if you are on an exemption list would be cause for denial of licensure.
No, I understand. I mean, the case with Miss Fisher, where, the person who assaulted her had been arrested for assault a year prior. And so I get the particular concerns. This was in the task force report, and I wanted to raise that. I also, OSSI isn't here, but I did want to, this problem is across multiple sectors, and I wanted to highlight more of, some of the work that OSSI mentioned. They have the career and technical education program that starts as early as middle school, the integrated education and training programs that support adult learners to attain the secondary credential concurrently with workforce prep, their DC Futures program, which provides up to $8,000 a year in tuition and fees for individuals who want to go back to school to get additional training and credentials. They also mentioned that they work closely with a lot of different industry partners, et cetera. I then am forced to come back to the question of who's responsible on the executive side for coordinating all of this? Who's the home? Who's the home of long-term care?
So I don't want to speak on their behalf at all, but when I think about long-term care, it's often our partnership with Department of Healthcare Finance is where we sort of focus the long-term care conversation is in partnership with them from the DACL side.
Okay.
So unfortunately, we're talking about healthcare finance and they're not here. But
To be clear, they were invited, but go ahead.
yeah, I would say for DC Health, we see the home as healthcare finance with us supporting that system with the licensure regulatory component, with the facility regulatory component, et cetera. But all of those things come into play. And as it was mentioned from the Healthcare Association, he referenced you have to have multiple processes that include, eligibility from healthcare finance. It's because all of these pieces touch each other, and admittedly, but I think they all touch each other at healthcare finance.
Yes, except for healthcare finance would probably say, we are engaged on the eligibility and the ensuring that a client is receiving the services, but we are probably not the appropriate person to solve this issue of how do we get the workforce?
I think
Right, because that's central of what we're here.
it's a shared responsibility. I think that's why we're all here. All of the agencies that are submitting testimony regarding the long-term care efforts. I think everyone has their part to play. Again, who is the coordinator and organizer? I think, again, healthcare finance maybe would be who all of the agencies identify that they work with in collaboration with more frequently. And so that would be why I would say they could be the executive of it. But I think it's a shared responsibility regarding the long-term care workforce.
I'm looking at my phone to see if Director Turnage is like, y'all are here talking about me, but I'm not there. To be honest, I feel like, to Councilmember Bonds' point, if we're going to have the plan, somebody has to lead the convening to bring all the agencies together and say, okay, what are we doing? What are you doing over here? What are you doing over here? What are you doing over here? And how can we support one another, in that work or sort of moving things along? When we're talking about the workforce in general, I also feel like in some of our other high need health areas, this is not a conversation we could start with a kid when they're in college, right? And in some cases, we can't even have this conversation started in just high school, but we have to hey, did you know about all of these opportunities that might be available to you? And how do you sort of work towards some of these things? But I'm over my time. Councilmember Bonds.
I would just like to add to your perspective, Chairwoman Henderson. We're also thinking about how do we get a wonderful supply of humans involved in this that are right there in the family element. That's where my thinking is. How do we develop a strategy so that family members can qualify as some of the workforce? They're already doing it in some instances. When you come home from your job, you're looking after your grandmother or your mother, what have you. But how do we really get them interested in this enough so that we think of it as a stipend program, which is an offshoot from the bona fide, healthcare worker, or just how can we do this so that we take care of our aging population that needs assistance? And how do we also get individuals in the workforce that perhaps are not in the workforce? Or how do we augment the income of a household so that they can have a better quality of life? And I'm hoping that we can think about that in depth and see what the mix is, because we're talking now about testing, we're talking about clearly some curriculum that, so how do we convey that to the population that it's a good thing to take care of an elderly relative or neighbor, you know, those kinds of things, very much are in need, in my opinion. So, am I talking Dixie or okay?
That is a very complicated question. And so I want to acknowledge that it is a valuable question and one that certainly should be explored, but it is a complicated one of how do we get from point A to point B. I do think from DC Health's perspective, I can say with the creation of HISPA, we are certainly satisfying our current regulatory obligations and maintaining our regulatory charge, but we also are trying to think of more of a system perspective of I can have all the beautiful facilities in the world, but if I don't have the healthcare and workforce to be in it, they're just buildings. Equally, I can have all the people in the world working in a field, but if I don't have somewhere that's safe for them to provide care, it's equally a problem. And so when we're talking about these things, we are trying to transition our mindset from I need to ensure that high quality and equitable care, but I need to ensure that there is a system in which that high quality, equitable care is delivered. And so I think we are working on this conversion of our mindset, which I think will start addressing this a little more holistically of how do we leverage resources, back to an earlier point, how do we leverage existing resources to the greatest extent possible while also ensuring that those individuals are receiving high quality and safe care. We've heard examples today where people did not receive high quality care, and DC Health took regulatory action in those cases. But it is something of how do we leverage other persons in the home? How do we leverage those things and make sure that they are trained and qualified to provide the care? Because what I don't want to do is I don't want to push off the responsibility of clinical care to someone who doesn't have that training and ultimately worsen the condition of the patient because they develop an infection or they develop something because they weren't qualified to do XYZ skill. And so I do think it's this, to use a metaphor, it is a dance that we have to do, but I think it is certainly a waltz that's going to be a long score, to continue with my metaphor, rather than a quick soiree. Thank you.
I appreciate that, and I want to be clear. I was not in any way suggesting that whomever takes this responsibility would not be trained. The point is you would be trained. And so it gives you an opportunity to think career. So I just want that clear.
So from DC Health's perspective, one of the things, and again, in shift of mindset on how we work and how we operate, again, we've been in a very much so regulatory space. When it comes to the boards, they develop what the minimum competencies are. And so one of the things that we've been challenged to do is kind of look at how we help build the workforce. So a large number of our teams go out to local schools, do presentations about the various pathways that's available. We do go to local schools and present to graduating classes about how you go through the licensure process. But again, we do go to schools. The Board of Nursing staff goes out and talks about the various nurse pathways. Our allied and behavioral health team, again, go out to our local schools that provide the rehabilitative services. So to talk to them about the licensure process so that they're able to have a smooth transition when they enter into the workforce.
Thank you. So DACL, have we thought about this? And how do we think about it?
Sure, yeah. I would say that at DACL, we don't oversee the workforce directly, right? One of our areas that we can really speak to is the impact that we see on families and individuals when there are deficits in the workforce and we need more support. And so DACL is willing to collaborate with our partners at DC Health, at Department of Healthcare Finance, DOES, any of our partners that we can work with to leverage that workforce and make sure that we're supporting our seniors.
Thank you. Thank you.
Okay, thank you. All right, I just have a couple more questions and we can wrap up. For DACL, you all reported during your oversight hearing that the community transition team transitioned 76 seniors as part of the Money Follows the Person program. When someone is transitioned back, what type of additional supports do they receive?
Sure. So thanks for that. Oftentimes, we are working through the waiver process prior to discharge. So they will be discharged to make sure that they have the hours of coverage necessary to keep them home safely. Sometimes that includes alterations to their housing. So we do work with them for home setup. So if an individual needs like a hospital bed or a Hoyer lift or other durable medical equipment, we'll work with them through that process. So everyone is going home with the supports they need to maintain living independently. We transition individuals also who might have individual resources or family support to set those things up as well. So the 76 is specific to Money Follows the Person, but there are other streams as well. EPD waiver, family, that sort of thing.
How many case managers do you guys have?
So we have two teams, community transition. They are community transition coordinators. So they work in the long-term care space to transition folks out. That team is currently 7. We have a vacancy that we're looking to fill, and we also have an outreach coordinator who goes and educates in the facilities about the program. And then our case managers, we currently, I can't think of everybody off the top of my head. I want to say 14, but let me also follow up with you specifically.
Okay.
But generally, that.
Okay. This question is for both of you, or both agencies rather. Are there any additional data needs that need to be developed or enhanced in order for us to like effectively move the needle on long-term care workforce? Like, is there some data point that you wish you had that you don't have, or something to that effect?
I would like to think about that more, honestly.
Yeah.
And our role in sort of in DACL's role in the whole process, since we are making sure we're linking our seniors to these services that are life-saving, what would be helpful from that lens? Take it back to Director Hines, talk with our team about maybe what that looks like.
Okay. Director Hurley, Ms. Nixon.
So when we're talking about data and workforce, this was one of the major projects that I worked on in Maine around EMTs, which similarly has a shortage and is a high need healthcare career pathway. One of the things that I think we have a real gap on is understanding the pipe. I like to call it the bathtub model, and I'm sorry to use metaphors, but
The bathtub model?
the bathtub model.
Okay, I'm gonna give you, go ahead.
And I would love the grace to explain this.
Yes.
Yes. So I like to call it the bathtub model, and the reason for that is there is a pipe coming into the bathtub, right? That pipe is, for us, the educational programs. So if I have a lot of educational programs, that's a big pipe. If I have very few educational programs, that's a small pipe, right? So I need to know how many are coming out. And I can put at the end of my pipe, I can turn the water off and on. So I have processes about how people, licensure processes, other things that regulate the flow from that pipe into my bathtub. My bathtub is the workforce.
Got it. Okay.
So if I have cracks in my bathtub, I have retention problems. People slip out of my bathtub and I have fewer people in my bathtub. If I am continuing to fill the bathtub up, then that means I have a recruitment strategy and I don't have, my retention problems are not exceeding my limitations. If my water's going down, then my retention problems are a significant issue because I can make this pipe as big as I want it, but if my
Just
water's
flowing
still
right
going
out.
down, I'm not holding water. I don't have good retention. So that's my bathtub metaphor for explaining this. What I can tell you is I don't really have a good idea of how much water is coming up the pipe. I know how big the pipe is. I know how many people are in, I know how many training facilities there are, right? How many people are interested in going to the training facility? So how many people are actually interested in this career pathway? Because I don't know how much water is in the pipe. Do I need more training facilities, or the reason we're losing training facilities because there people aren't interested in doing this? I don't know the answer to that question. And that is one of the things is I need to understand all the components of my proverbial bathtub model to make sure I know how much water is in the pipe, how big the pipe is, and then how many cracks and fissures do I have in my bathtub? Because I will tell you, when we looked at it in Maine, for example, we had a lot of cracks in our bathtub, and my biggest problem was retention. I could get people in because, oh, come be this healthcare professional. It's a great experience. We have, as you heard today, healthcare professionals, proclaiming this is a great career and it's rewarding for them. And then someone gets into it and they decide, oh, this is not for me, or the wages aren't where they want it to be, or the career ladder's not there for them to grow, or they're having poor experiences with patients. There is abuse against healthcare professionals too. All of those things come into play. And so fully understanding that model those are some data points that we need to work on collecting. And that's partnerships with our educational facilities, expanding those partnerships, and expanding our partnerships with other community or other district agencies, OSSI, and public schools, et cetera. Also, on the flip side, so the people in the bathtub, we need to better understand our workforce survey, and we are making changes to our workforce survey to understand why people are leaving. Did they start in this career path, or are they ending in this career path, or are they planning on using this career path as a jump? We found out for EMS, particularly with our collegiate-based EMS systems, this was a stepping stone because PA school requires you to have clinical hours. And so that's not a problem, but it's something we need to know as we're understanding the workforce, is that you get into this so you obtain your clinical hours so you're eligible to apply to PA school, which required the 2,000 hours of clinical hours before you could even apply. So it's fully understanding the bathtub that we're really trying to do. So it's understanding the pipe coming in and understanding the people in the tub with the workforce survey that we conduct every time we issue the license.
It's actually a very effective metaphor that could be used on a variety of different things. Like I'm thinking like, wow, we need this for OUC with our 911 call takers. I think you got some cracks in the bathtub. But the point is, do I understand all of the other pieces there? Certainly for EMT as well. Is the source of that information though, because I also feel like at least in the healthcare sphere, and we can say that for the professions within the long-term care space, whether that be CNA, HHA, medication, what'd you call it? The medication aids, OT, PT, nutritionists, like to what extent do our coming up generation or folks who are looking to make career changes recognize the variety of career options that you can have that is not just physician or just RN? I don't know if we've done a really good job of explaining all these other things that you can do. Phlebotomy, right? You know, like there are a variety of different things that we need you. You're in low supply. And in some of those instances, those jobs don't require four-year degree and an opportunity to, you can sort of grow. But I don't know if we've done a really good job of promoting the full ecosystem of what does a health workforce contain beyond a physician.
I wholly agree. I do think that the programs that we are doing with the ATCs and with OSSI about getting young people engaged with these programs, and as part of that engagement and as part of this training, it includes clinical opportunities. You get to see the people doing the jobs. So that's what's attractive about it. You know, seeing the firefighter fight the fire is what makes firefighting attractive, not the, you know, seeing just the building there that has two gigantic doors and a big truck behind it. It's seeing them in their field. So seeing the occupational therapist working with the patient and being able to see that through your clinical rotations. This may not be your endpoint, CNA, HHA, that may not be your endpoint, but having the opportunity to get in the care space and see these other healthcare professionals, because I don't think we do a great job at talking about all the vast opportunities that are available within the healthcare sphere. But the best way to see it is to be in it and to be able to see these people work with your patients or work with the patients that you're interacting with. Because then you're like, I want to do that.
Yeah, I mean, I think there's something to be said for the in-person opportunity, but I would also say some of we would be kidding ourselves if some of the sort of iconography of like some of these very known professions are not driven from media perception or narrative, right? You know, a whole bunch of people who went to med school because they liked ER. Right. And they wanted to be like George Clooney, or a whole lot of people who are interested now in firefighting because they saw, I don't know, fire 911 or Chicago, something, right? You know what I mean? Like some of these, they're not the sexiest, but on TV, you know?
I agree with Senior Deputy Director Hurley. It is about being in that space. I will say how I picked my career path, even though it's different, was about that exposure. So I'm like, oh, I want to work with when you end up having to go to PT or go to rehab with your grandparent. That's how people get exposed. I know a lot of people, like you said, that they started school and they were like, oh, I'm going to do medical school. And then they started doing volunteer work, right? And so in doing the volunteer work, they worked in the rehab department and they decide, oh, hey, I'm going to be an occupational therapist. A lot of nursing homes utilize the CNAs to do their basic daily exercise groups, like individuals that are not on therapy. And so that person is who typically collaborates with the rehab team. And then they decide, hey, you know what? I want to pursue becoming an occupational therapy assistant or a physical therapy assistant that does not take a 4-year degree. It's still 2-year programs.
Okay. All right. Well, I don't have any further questions. Councilmember Bonds, do you have any other questions for this group?
No further questions, but I want to thank you very much for being here. And as I was relating to my staffer, you know, this seeing the career in person does influence you tremendously. You know, you start out, you graduate with certain credentials, and then something happens and you try something else out or you volunteer, and then you realize this is where I need to be. So it's your jobs to think about how we can, as Councilmember Henderson says, move the needle so that we're really getting more people interested in this work, because this work will be here as long as we're here. And how do you get people to think that way? How do you get families to move in that direction? So think about my idea. I think it has some merit. I think it can begin to move some mountains. too. So thank you. Thank you very much. It's been a pleasure to be here with you today.
Thank you, Councilmember Bonds, for doing this hearing together. I think we have some takeaways here in terms of what we have to work on next steps. And I do also want to mention for the people who might be listening, who might be alarmed that we haven't talked about wages. We did a long conversation about wages. We passed legislation about wages. And so we're very aware that the wage conversation is part of it. But to use your metaphor, there might be some other pieces here that we need to pay attention to the whole apparatus, not just a part of it, because we could raise all the wages we want and still not fix the issue because of other types of things. And so one of the things I think we're going to look to on the Committee on Health is certainly following up on some of these training program pieces and supports, and really how do we work this with OSSI to be a bit more creative and thinking about building that pipeline from our young people as well as our young adults into this work. And then even some of the issues that were brought up today, I think for the first time, around some of the other regulatory issues, right? Tort reform, et cetera. I know, don't come at me, trial lawyers, but like, I think we do need to have a conversation. We did this with certificate of need, talking about how do we reduce some of the barriers for facilities for providers to come into the district. And I think in terms of, the other question, all right, do we have enough workforce, but do we have enough facilities? If someone, for instance, wanted to say, you know what, or if a family wanted to decide, you know what, actually home care might not be the best, an assisted living facility might be the best for our family situation. Okay, if they make that decision, now do I even have a spot available? And I don't think we've had that conversation around, do we have enough beds in that realm? So we're going to follow up on some of that, and then of course the cross-government support. But this concludes today's Oversight Roundtable on strategies to support the long-term care workforce. I want to thank everyone who provided their testimony. For those who were not able to attend or speak today, we'll accept public witness testimony until Wednesday, April 9th at 5 p.m. You can submit your written testimony via the council's hearing management system at dccouncil.gov/hearings. You just click on this particular hearing and there's a little button that says submit testimony and you just hit upload. Our next hearing for the Committee on Health, it's a joint roundtable with the Committee on the Judiciary and Public Safety on a sense of the council resolution about crisis response. That will be on Monday, March 31st at 1 p.m. Councilmember Bonds.
Okay, and I will add that the Committee on Executive Administration and Labor will hold a hearing on the 7th of April, and we'll be talking job training and workforce development throughout the district and the different processes. So thank you.
Yeah, all right, and then it's 4:32 p.m. and this hearing is adjourned. Thank you.
Thank you, ma'am.